Good morning, friends. Today is February 13th. It is considered as the International OMFS Day. So today we are celebrating the International OMFS Day by lots of programs in almost all the branches all over India and all over the world. About 10-15 years back, I happened to go through an article where how much the people know about our specialty of OMFS. Yesterday, most of you have attended the installation where our chief guest was talking about our industry as a whole, and that itself shows that the awareness of even the learned people are not very good regarding the dental profession. And coming to maxillofacial surgery, which is a specialty of the dentistry, it is very little people know about the maxillofacial surgery specialty as a whole. Actually, during the past 10-15 years, we discussed these things among our friends in various conferences. And in 2014, I gave such a topic to one of my PG students, and he studied the regarding the referral to oral conditions among healthcare professionals. And here he assessed the awareness and knowledge about the oral and maxillofacial surgery among the healthcare professionals. Actually, nearly 400 people were included in the study, including medical and dental doctors in different clinical departments in various hospitals in Trivandrum. Basically, the faculty members of the government and dental colleges of Trivandrum were excluded. And study participants were divided into 4 groups: general dentists, dental specialists, medical practitioners, and medical specialists. Questionnaire was given, and nearly 400 people responded. And as conclusion, we can say that the perceived knowledge is only average among the healthcare professionals because of this lack of knowledge in the health professionals. And many healthcare professionals still associate with intraoral condition tooth removal only. Many other specialties usually have tried their hand, resulting in a lot of problems. Healthcare profession still lack information regarding the overall scope of the oral and maxillofacial surgery, and our specialty mainly overlaps with plastic surgery and ENT. Among the dental practitioners, and it was found that most of the people are aware of the oral and maxillofacial surgery, and their references were actually in a very good rate. So today I am just going to give you some examples of the scope of the work of the oral and maxillofacial surgery as a whole, especially with regards to the newer technology which is being used. This is a patient which reported to Dental College Calicut after head injury after 8 months. And the first picture shows the condition of the person. And initially the surgery was done. And the second picture shows how he was after the first surgery. So the first picture here shows the pre-operative mouth opening, and the second one, the post-operative mouth opening. And this was the extent of injury he had sustained at the time of accident. And this again shows how much fracture has happened. And this particular radiograph shows after the first surgery, you can see the plates and screws in place. On the reconstructed zygomatic arch also can be seen. And in this 3D CT, you can see the various bond plates fixed at different points of the body, on the nose, on the lateral aspect of the eye, zygomatic arch, etc., etc. Now, when he presented at this condition after nearly 2 years, now it is almost impossible for us to fracture, refracture, and correct the procedure. So we went in a different aspects. We took 3D CT, and as you all know, the CT is usually stored as DICOM images. DICOM means digital imaging for communication in medicine. This, with a technology, you can convert it into stereolithography. With the stereolithography, you can print this thing, print the whatever part you have taken, and then with the use of the CAD/CAM technology, you can actually plan your implant. So this is a picture of the stereolithographic model. And then what we did was we made a titanium implant with an orbital extension. And the plan was to put the implant through an intraorbital approach and then remove the plate which was exposed and close it with primary flush. So this picture simply shows how this implant was placed, and the second one is an immediate postoperative picture. And the first picture here shows the initial presentation, and the last picture, second picture, shows how he was after the placement of the implant. Now coming to another case, this person had lost a part of the cranium and his orbit was accentrated following the road traffic accidents. He came after nearly 2 years. So similar procedure was done. This shows the missing calvarium. Similar process was done, and this was implanted onto the patient's skull. As you can see that the skull continuity is restored, and an implant was placed into the orbit also. This is a case where of an amyloblastoma, where we use the same technology for correction. You can see the extension of the amyloblastoma in the CT scans. And then we printed out the mandible by flipping the normal side to the other side so that the whole mandible was prepared and an implant made according to that. Then we went with the free fibular microvascular flap. And here, instead of the normal this thing, I did the double barreling of the free fibular flap. And as you can see, it gave you excellent results. You can see the first picture on the left side shows the intraoral area of the person. And on the right side picture shows an earlier case where double barreling was not done. You can see the deficiency of the ridge in the that right-sided case. So, as far as the prosthodontist is concerned, having if you do this sort of double barreling and you do the reconstruction like that, it is going to give you very good results. Now, this is a last case of an aesthetic problem where this boy had a mandibular hyperplasia with the side of the mandible drooping down. This X-ray actually clearly shows how much the mandible on one side is tilted. And again, we printed the mandible out, then made a stent pose, removed, and it gave a sort of reasonable aesthetics to the person. I presented all these cases just to show that the maxillofacial surgery as such have improved a lot, has advanced a lot, and that the present today's topic actually is going to deal with the mainly with the complications and the impaction, infections, and those sort of things. So this slide was given only to make you aware that the maxillofacial surgery has much further scope. Over to the moment.
Next, over to Dr. Sameera for the introduction of our faculties.
Good morning, friends. Warm greetings from IDA Malabar branch. This is Dr. Sameera, wishing all my maxillofacial surgeons today to all my friends out here. And today we have 3 topics from 3 stalwarts in the field of maxillofacial surgery at Calicut. And the first topic for you is about difficult extractions and impactions. And the topic shall be dealt by none other than Dr. Soumithran CS, who is the principal at Government Dental College, Calicut. Sir did his BDS from CODS Manipal and MDS from GDC Calicut. He has 30 years of teaching experience and was a professor and HOD in maxillofacial surgery for 18 years. He is a former Dean of Dentistry at the University of Calicut, and he is a regular speaker at national, state, as well as international conferences. And he has many publications in state, national, and international journals. Over to you, Soumithran, sir.
Yeah, very good morning, everybody. So I'll share my slides to you, and we'll start with the topic that is the impaction surgical management. I'm audible now, right? Am I audible?
Yes, sir. Yes, sir.
Yeah. So 1 second, I'm just sharing the slides. Can you see the slides now?
Yes, yes.
Okay, fine. Yeah. So very good morning to everybody. So as rightly said, today is the maxillofacial surgery day, and Dr. Ravindran and I already told you about the scope of the maxillofacial surgery and the way in which the specialty is growing. And today I've been given a topic of surgical removal of third molars. And before starting, I just bow my respect to my professor, Dr. N.S. Rajivan, who is a teacher of many of us in Calicut region, who was our first professor. So it will be a right day to remember him on the day of maxillofacial surgery. I also take the IDA Association to take up a program on this day, commemorating International Maxillofacial Surgery Day, and arranging a program like this in a short time. Sudhir and team has done a very good thing of putting very clinically 3 important subjects to myself, Dr. Ravindran, Nair, and Manoj. And I'm starting with the challenges in surgical removal of impacted teeth. What are the problems you are facing? How do you manage to do a surgical case of an impacted tooth? So impacted tooth, I'm talking about this impaction mainly with the general dental practitioners in my mind. So I will not be talking about the very difficult or tougher cases which require much extensive surgical plan and things like that, but straightforward cases which a general practitioner who can manage in this clinic. So those areas I'll be touching up, and I'll be going through the slides, and I'd finish within 30 to 35 minutes. So I will limit to certain all areas I may not be able to contain within this. We also have a discussion time after that. So straight away, I'm going into the topic. As definition, you all know, as according to pictures, and it is the impacted tooth that failed to erupt into the dental arch within the expected time. So what are the indications why which usually a patient comes for a removal of an impacted tooth? Usually caries or a pain. Sometimes there's atypical facial pain, radiating pain, which goes into the ear and eyes and to the entire region on that side. There will be pericoronitis, typically in the oral cavity, you can see that. There will be a periodontal pocket distal to second molar and in between 7 and 8, which gives trouble to the patient. There will be a resorption of the adjacent tooth. And there will be sometimes a pathology, cyst or a tumor, mostly a dentigerous cyst along with it. And sometimes for orthodontic purpose, as the push comes from behind, the crowding in the anterior region will be relieved if you remove an impacted tooth. So that is one of the indications. And the compression of the inferior alveolar nerve by the tooth, which rarely is noted. These are the common indications by which a patient comes to you for a removal of. Remember, a strong indication for removal of impacted tooth be complemented with a strong contraindication to its retention also. So which are the common things? Sometimes we remove a tooth when the patient comes with a mandibular fracture in the angle region. Because of that, the tooth is also involved. There is a wood fracture or the tooth is split vertically, you may have to remove it. Recurrent pericarditis is the most common cause for a removal of a third molar. And this happens when the tooth is erupted. You have the operculum there and food collected there, and they'll be impinging by the upper 8, and the patient may require removal. And a deep pocket formation, distal to 7 also. The 7 also will be destroyed eventually, and a proximal caries comes. Or a canine, in the case of an impacted canine, which is retained, a retained deciduous tooth, which prevents the eruption. It's a common situation. We end up, sometimes we can surgically expose and bring it into occlusion. So you actually really remove a tooth when it is really indicated. Otherwise, sometimes you just observe, and if it is asymptomatic, leaving that will be also a very good choice. That's what you have to decide whether to remove or not. Now, caries in adjacent tooth and adjacent to a cyst or tumor, or a displaced one outside the arch, which can never be aligned. These are the things usually we go for removal. Now, contraindications, just going through the contraindication: extremes of age, compromised medical issues, excessive damage to the adjacent structure. If you have to remove a lot of bone, and it is going to be more damaging. And so risk-benefit ratio is always being taken care of. Third molar sometimes needed as abutments. As a prosthetic purpose, we will retain it. For a recently irradiated jaw, you can get a necrosis if you remove in that time. So these are various contraindications which should be, all of you should be very aware about. And a surgeon must know when not to operate than when to operate. That is very, very important. So absolute contraindications, we usually say is acute pericarditis. If you try to remove that time, your anesthesia may not be working well if it is under LA, or when the patient having an ANAG situation, which is a widespread infection. Don't create a surgical wound in such cases. Of course, bleeding, things like hemangioma and hemophilia, very rarely you may end up with a hemangioma. You will never notice. Whenever you have a third molar patient, or any extraction for that matter, comes and you take a radiograph and find a radiolucency of a well-defined one. Don't always think that it may be a dentigerous cyst. A possibility of a vascular lesion should be there. One case we had here, I think when Nair was here as a HOD, had a severe AV malformation, and somehow the patient was survived while trying to attempt. The bleeding started from a clinic, and the patient have come here. So always is mandatory to have an X-ray, a good X-ray in extractions also, to look for a lesion inside. There will be no clinical symptoms. There will be just a radiolucent lesion. Unfortunately, it could be a vascular lesion. You may not get much clinical sign also sometimes. That's a risky thing. Or there will be pulsation, or the tooth will be moving in the socket. Such features, it is very rare, but if it happens, it will be really, really life-threatening. And thyrotoxicosis, some of the reasons why when the thyroid is toxic, what happens, medical issues. And for any surgeon, the knowing his anatomy is the most important thing. Before you take up a surgeon, or a dental surgeon especially, I'm stressing on this. Before you take up any surgery, you may be able to do any surgery, minor, in your hands with adequate training and a good knowledge of the anatomy. That is very mandatory. Otherwise, if you're not sure about the anatomy, you're not sure about the procedure, it will not be better to give a date for surgery and try to operate. Okay, make sure that you're very thorough in the thing and you have adequate experience, learn it properly, then slowly start with. That's the way practitioner can also do some certain not very difficult or moderate infections. You can handle it by yourself. So the retromolar triangle, of course, you have very vital area, just distal to third molar, where the temporalis attachment, you should be knowing the pad contains retromolar vessels. Don't transect that. Don't transect the temporalis, which may produce post-op trismus. Don't go lingually with your incision. The lingual nerve passes close to that area. Don't damage on the lingual mucosa on that side, which is very vital area. So these things you have to be very careful. The anatomy of the retromolar area you should be knowing. You should know about the lingual and inferior alveolar and long buccal nerve branches and how it runs. What is the connection with the teeth and the canal. Nowadays, with the cone beam, you can very nicely three-dimensionally see all these structures, and most of the headaches are over nowadays. Even though it's costly, it's a very useful, many investigative things are there. And the importance of a lingual pouch. If you extract a tooth here or a third molar, if the lingual plate breaks and the tooth can be displaced into the submandibular area below the mylohyoid, you cannot retrieve it out through this route. You have to go for an extraoral approach later on, because those things can happen if you are not very judiciously don't do your procedure. So lingual nerve, you have to be very careful. It is around 0.6 millimeter medial to the mandible, 0.6 millimeter only, and about 2.3 millimeter below the alveolar crust. This is a common measurement, but there will be a lot of range between. It may be much lesser than 2.3 also. So that you should keep in mind. Don't play with this lingual side and the lingual plate of bone and the mucosa. Be very careful. Even with your instrument, stretching and pulling on that side, or trying to chisel from here, all can damage the lingual nerve. And the paresthesia will be so troublesome. In Western countries, people will sue you if you make a lingual nerve damage. Here also, it will be a problem. The future generation also, everybody is going to be complaining about that, and it may not retrieve. Patient may suffer it for years. So a lingual paresthesia should never try to produce in the patient. Of course, the vasculature, to be very careful. The inferior alveolar artery, which runs within the mandible, it doesn't come in the impaction area, but in the apical area, it is there. You do inadvertent damage by puncturing into that socket, or put a burr there and nick the artery, it may bleed. Okay, so that may be troublesome in the clinic, and management we may tell later, or in complication, Nair will be telling about that in intraoral bleeding. And lingual artery on the lingual side, very unlikely to get damaged or cut during our surgery. If you slip an instrument or iatrogenically, you may puncture the lingual mucosa, and deeply if it goes, it may cut the lingual artery. So then it can be troublesome. These are very rare. If you do very carelessly only, such things can happen. And facial artery and vein doesn't come in the procedure of impaction, but it comes while doing an incision. In your anterior limb of the impaction, when you're cutting down, don't cross the mucogingival junction. Just stop short of that. The best way to do will be to start from below up rather than coming down from the crust to the mucogingival area. Start with the BP blade from the mucogingival area and take it up. Then that will definitely protect your facial artery. It may cut down deeply and cut the facial artery. Again, you'll have trouble, especially for a dental surgeon. If you take care and do that, there's no way going to cut any of these vessels. So that should be kept in mind. So the vasculature, the nerve, and the muscles attachment, and the structure where you are operating, very clear sense, the anatomical place, okay, all should be kept in mind. Plan well and do very safely. So there are many classifications. I'm just, for the sake of academics, I'm just mentioning the mesioangular. Typically, everyone know, according to the position, you have all these varieties, bucco, angular, lingo, angular, and bucco version, and all those things. With the cone beam, now you can see there is a bucco version. Where is the, it is on the closer to the lingual plate or buccal plate. With an IOPA is difficult, but the new modern CT and cone beam, you can very nicely plan your surgery. And Pell and Gregory, everybody studies in dental BDS itself. Class 1 is according to the level, and the relation of the ramus of the mandible is taken here, whether tooth is fully outside or partially in the ramus or fully in the ramus. Okay, fully in the ramus, of course, it's going to be really difficult compared to the one where there is adequate space. And same way, position, you have the position A, B. A is 7 and 8 in the same plate. And the one B is in midway between the crown and the cervical margin, and C is below the cemento-enamel junction of second molar. This is going to be really tough. You say, as for every 1 millimeter of depth here, the procedure is going to be 3 times difficult. So in these kind of cases, it will be better sometimes do under GA. Under LA, it is going to be really tough, and don't encounter and take up such cases if you are not very good in that or an expertise in that. So classified, there's a classification now on the basis of a cone beam CT. You can see, if you refer any of the textbooks or Nilima Malik and all, you can see those nice pictures very beautifully that will tell you the connection of the inferior alveolar nerve with your root ends. That is a very vital thing. And in cone beam, beautifully you can tell whether it is passing through the roots or adjacent to it, or there is already a compression on that. Can be very well studied. IOPA will never tell you. We used IOPA technique for long years, decades. And we may make error also with that. And the modern images will give you an excellent picture of the course of the inferior alveolar nerve, and whether it is bucco version or lingo version. Now, maxillary, I'm just briefly telling maxillary and canine impactions also. When we tell about impaction, everything is covered. But predominantly, we'll be talking about third molar lower impaction, which is very common and very commonly operated. So the angulation wise, you have classification for that. And the maxilla, the bone is thinner and the removal will be easier, but the access is going to be really difficult. And it's got its own complications compared to the lower jaw. Okay, and sometimes you have to go for a wider flap, and tooth will be within the sinus. We get it anywhere in the sinus. We get it in the floor of the orbit. Sometimes we have seen it in a very distant areas also. So it's a challenging cases then, but straightforward cases like here, the tip can be seen and in the same level, and the X-ray shows no dilaceration or hypercementosis or anything. You can just luxate and it comes out easily. Okay, just with an elevator, you cannot apply a forceps most of the time. Just with an elevator, very safely, you can slowly luxate and take it out. Most of the upper third molars You can handle that way. Otherwise, you have to plan accordingly and take a flap and go for open method. Now, assessment is very, very important. I will tell you, assessment start with of course, the medical assessment of the patient, whether he's fit for surgery, all his general other diseases, and the conditioning of the patient. It is very important before you start with is healthy, whether he's anemic, whether he's hypertensive, diabetic, all has to be checked very thoroughly in any surgery. That is very mandatory, even for your dental extractions. So it is very mandatory, and all clinicians must do this in their clinic. You may be having busy practice, but don't mess around with such things. Now, extraoral examination. In the case of impaction, we have to see the facial form of the patient, how well built is the patient, the flaring of the ramus, the very cheek is so bulky and thick. This is going to create real problem. If a cheek so thick, your surgery is going to be a real trouble. And a swelling present along with the tooth has to be examined. Presence of a sinus or a fistula. You don't miss out on any point. Extraoral sinus may be a sign of a osteomyelitis or a chronic infection with the tooth, or there may be an infected cyst inside. The lymph nodes you have to check. The nodes are tender or palpable, or any other pathology are there. Is there a ameloblastoma under the tooth? An extraoral swelling, you don't neglect it. There is an extraoral swelling, no clinical sign and symptom. Always go, never do without an X-ray. Even an IOPA won't show you. That's why we say OPG is mandatory in an impaction, because you may miss out bigger lesion, which is likely to come. OKC is very common with an impacted tooth in a young patient. Okay, and trismus for the patient is present or not. Okay, so make him perfectly all right before the surgery you undertake, and anticipate the issues. A bulky tongue, that is going to give you trouble. Intraorally, you see mouth opening, the rima oris is small. You're going to have a big headache. You cannot put your instrument or micromotor. Your assistant cannot put a retractor on the lingual side. It's going to be troubleshooting for you. And the mandible position, the retrognatic mandible will going to give you tougher issues. The access will be more, and tongue size and cheek, that is a real problem. You will not get access, and you cannot see the area properly. And excessive salivation. Keep a very good suction, a very expert assistant with you who really knows what you're doing, and that makes a lot of headache out of your system, and you can handle very well. A very good assistant, nice light, equipments, instrumentation, and arranging everything is important. The lips and cheek extensibility. Otherwise, all will produce soft tissue trauma to the patient. Dentition status, you have to see. You have to see the external oblique ridge. That is going to be a point, because it comes sometimes just on the buccal aspect of third molar here. If your external oblique ridge is adjacent on the buccal side, the buccal bone removal is going to be really difficult here. Okay, if it is the ridge is behind, you have much less problem. But this is going to be one real issue if you have the external oblique ridge here. And the internal oblique ridge also you palpate. That gives the level of this external and internal oblique ridge, gives the level of the attachments of the other muscles, buccinator coming down here, the temporalis coming here. Okay, so be familiar with all those musculature, and nice clinical palpation, and prepare and thoroughly do an extraoral and intraoral examination. The clinical examination of the pericoronitis, see the status of eruption, whether you can sometimes save the tooth, if it is erupting into position. 8 is also, upper 8 also into position. You just do an operculectomy, cut off this gums which is hanging over there, the operculum. You cut it out nicely, scale it well around, apply some chlorhexidine and all, irrigate and do a good brushing. The teeth may be in function with upper 8. You don't have to remove it. There is no need to remove in such cases. Okay, operculectomy is a very good method. And when a patient comes with acute pericoronitis, what we sometimes do is don't jump and try to remove this. Remove the upper 8, which is impinging, and it is not non-functional. Remove the upper 8, give antibiotics, and flush here with the hydrogen peroxide mouthwash or antibiotic. The pericoronitis will be solved. Okay, impingement goes, the trauma goes. That is one of the elements in pericoronitis. So there are various ways by which a surgeon takes up. He will just do an operculectomy. They will do the upper 8. This 8 is never going to be a problem. Okay, or you see that 8 is tilted, it is not into function, there is no upper 8, and recurrent pericoronitis is coming. Then you think of removing it. Okay, so this is okay. Now, like that way, you have to plan for each case is different. And I'm telling you, some of the impaction look very innocent. You start with it and you have real trouble. You may stop not removing it. I have my own experience, 2.5 hours trying with some impaction. You think it was so easy, but just a little tricky, distoangular, a little bit vertical, a little down. You are going to have a real headache. It's not going to come out. And never do without X-ray and other proper examinations, because you may not see a dilaceration or a nerve involvement or anything. Okay, these are vital points. So the planning is very important and then the execution. Radiographically, I also already told you a typical IOPA and a bite wing and a occlusal radiograph, which also helps to see the tooth structure and the crown area and the entire bucco-lingual width also. But with the CT and if possible, you can get a digital imaging, CBCT, the things are much better. Extraoral X-ray is very good, especially for any impaction. As I told you, there is a possibility of a OKC or a dentigerous cyst and rarely an ameloblastoma, and you will never notice it. There will be clinically no swelling, and you try to remove the tooth, it will very nicely done impaction. By the time you just elevate the tooth, the mandible breaks. So this happens, and then you see a pathological lesion there. Then the patient is definitely going to sue you, because you are telling, oh, there is a cyst under this. I have not seen that. Now I am seeing it. I will do an operation. No, he said you should have detected it before. And told me, and this is going to healing also will be a problem with a pathological fracture. So periapical radiograph, these are the common things which we see. It should be very ideal. It should give the entire third molar picture, connection with the inferior alveolar. The architecture of the bone should be nicely shown. Relation with the 7 should come. The angulation should be correct. A typical good X-ray is required, or you will wrongly think that it is a vertical impaction only, or it may be a distoangular impaction. Angulation in the X-ray, your diagnosis will go wrong. Clinically, you can't do anything. You can only see the tip of the crown. So extraoral radiograph, as I told you, that will give you the entire ramus picture on the whole area and any lesions. You can see multiple impacted tooth. There may be other syndromes where you see many cysts and many other impacted tooth scattered all over the jaw. You may be seeing only one third molar, do an IOP and remove it. There will be many other in the jaw or any other pathologist. So always good to have a good larger X-ray. Is recommended and mandatory to have a lateral oblique or an OPG to rule out a lesion, which usually comes in association with the third molar. So of course you can see a radiolucent lesion also. So that is very important for an extraoral view. CTs of course will show you all kind of ectopic positions and whether it is neoplastic or inflammatory process is happening. And cone beam will very beautifully tell you in all dimensions where the tooth is located, buccally or lingually, what is the height, where is the inferior alveolar canal going, what is the relation with the tooth. Beautifully you can get and show the patient and tell, see the nerve is like this, the nerve is going through the roots. When I'm removing, your nerve may be damaged or it may be cut. Okay, has to be educated to the patient, recorded in your medical legal sheet, and take a consent before the surgery. Okay, this is mandatory. Even for extraction, it is better to have a consent. You have to take a consent. You are giving local anesthesia. You have to take a consent ideally. Something happens, you may not get escape if you didn't take a consent. You are worried about the patient's life, not the legal cases. So you have to keep in mind that the patient is protected at any cost by the surgeon. So nicely tracing the IOPA is very nicely done. Most of the postgraduate trained like that, marking all the things and conducting a difficulty index assessment and all the thing, and only they take up the third molar impaction. And I recommend same thing to the dental surgeons also, who draw the things and find out the difficulty score and how challenging this case is going to be. Then only you take up. It is a very simple thing. You can trace and find out the thing. You have to look for the follicular lining. Any pathology follicle thing getting should be sent for biopsy. Okay, it may be a unicystic ameloblastoma beginning, so send anything for a biopsy. Okay, see the root, you can see the canal, the two lines going. Okay, is it closer? Is it impinging? Is there a sudden disruption of the line? Is there a radiolucency on the canal? Okay, now you don't have to depend on IOP alone with the cone beam scan, which can very clearly tell you this has got our own limitation. We can't tell that. Look at second molar, whether the roots are conical and fused. You try to elevate it, this will jump out of the socket. Always look on the second molar. A gray RCT done second molar will break. Then he is going to give a problem. Okay, or the patient is having trouble. Okay, so see the second molar, see the status of second molar. A big proximal caries, the crown will break. Okay, and look for all the follicular lining, inferior alveolar canal. Don't miss out on any clinical points. And warfare assessment, I'm not going to those. This is there in all standard textbooks, how a scoring is done and why the points are given and how that give a difficult score for you. Very easily you can do that. Measure it, make it a practice to make a file for that. Score it and tell, just make your own assessment before you do the surgery. And Pedersen scale, mesioangular, the points are given like this. Mesioangular, only 1 point is given. Horizontal is 2. Distoangular is given maximum point, 4 in this one. Relative depth, class C is the deepest one, which is given 3 points. Relation with the ramus, class 1 is enough space. Class 3 fully in the ramus, tooth fully in the ramus 3. So you add up all these 3 score. What happens is, you know what is the total score? And the total score is 7 to 10. It is difficult, very easy. Moderate, then moderate. Don't jump into this difficult because it is really going to give trouble. Tooth is in the ramus, the depth is so high. It's possibility of mandible fracture, possibility of stopping the procedure, halfway, everything comes. So you have the typically all of you might have studied in your undergraduate, a white line, an amber line, and red line is drawn. A white line is over the occlusal surface. The amber one drops to the interdental area from that line, and the red line from the white line, from the amber line to the point of elevation. The amber line is from the intercrustal bone from the distal area of 8, drawn like that. And dropping a line from point of elevation is the what you call a red line. Okay, so depth of red line is a very important things to be counted. If it is distoangular, the point of application will be distal side, and if it is horizontal, it will be in the CEJ junction. So that way you have judgment of all those things. You can use Pedersen thing, WAF's analysis, but none of them cover the extraoral thing and other certain findings. Patient's cooperation and the cheek or tongue, nothing is scored in this thing. So we had a study in our department only where we scored the other things also. The cheek, the tongue, everything is given score. The retrognathic mandible and a newer scale system which we have published also. That you can I can put it in your group and you can go through that also, where other things are also considered. Now just going into the literature, how interesting is that in 1848 is the first second molar impaction was removed. The reported removal by John Toms. Remember 1848. In 1895, the grinding of the distal surface of second molar was done. Maybe to felicitate the eruption of third molar, I think, or to prevent a pocket formation in 1895. And in 1890, the first time a flap is raised and the bone is removed. And the bone is removed, they're not mentioning the equipment which we used to remove the bone. There was no chisel that time. And we have heard in the history, extraction are done by using stones. Okay, and those are the period in that time. There is no asepsis and there is no antibiotic and there is no instrumentation. Now coming to 1918, the first tooth sectioning was done by Edmund Kells. But remember these people who did explode and did all these things. And Winder in 1926 is the first one to use chisel, and that was called that time ossisector. That's the name given. From there we have evolved and come to all today's micromotor cutting system, the rotary cutting, piezoelectric systems, and the lasers, and many things. Piezoelectric system is a beautiful thing to do impactions. Okay, and costly, and you need little expertise and training, and you can use with that system also. Okay, and now the advantage of that, you can go through piezo system, what is the advantage, laser, what is the advantage, micromotor, what is the advantage, chisel and mallet, what is the advantage as well as disadvantage. Now an armamentarium, this I tell all my students right from BDS time and MDS time, everybody around, and my teachers also tell, always arrange instruments like this, and they never do it. Every time I have to go after them and tell, you have to go after them, you terrorize them to keep it like that, keep it in the order. In dental clinic also, keep it in the order and do, even extraction. You always start with the inspection instruments, mouth mirror, probe, and tweezer, first thing. Okay, then periosteal elevator. So it is in the order, where is periosteal elevator placed. You don't just make it into a sample. Then a BP blade. Then artery, then comes the scissors, then comes in that order of doing, micromotor, anti-suction tip you can see, mouth prop you can see, and the sutures and bound files and irrigation and bone ronger and all the things, and any packs, it is kept in that order, nicely sterilized. So these are the steps to be followed. Everybody knows the steps of that. I'm just rushing through that. But you have to follow this sterilization and instrumentation properly, plan your incision, plan your surgery, good anesthesia, osteotomy, then odonectomy, then removal of the tooth, debride very well, irrigate and close it. Okay, systematically go through the procedures. Principles of flap, all of you know, I'm not repeating it. What are the basics of flap? All should be followed. And maybe in discussion, we'll tell on that if anybody had a question on that. The incision, typically we use wards and modified wards incision for an impaction. Anterior limb and the posterior limb, and what is the significance of that? Maybe in discussion time, we will be able to tell that, because we have 2 more talk after this. The Watts incision is a simple one. You don't need much access. One anterior limb by here and a posterior one. And more access is wanted, or the vestibular depth is lesser, you go for a modified incision. Take it a little more anteriorly, a wider flap can be available, or for a deeper impaction, you need it. A triangular flap or envelope flap. There are a lot of flaps designed. You can go through that. Once you raise that, you gutter and plan the bone removal, how you are planning, what instrument are using. A chisel and mallet nowadays, much of us don't use because of the psychological trauma for the patient, basically. Otherwise, it is an excellent instrument. And in the old age people, it's not a good instrument to use because of the dense bone. A good retractor, an Austin retractor or a Bowdler Henry retractor should be used. Nothing else. Don't pull the lip like that and apply some the corners of the mouth some steroid cream so that you won't get a cut on the angle of the mouth. Okay, you always think about the patient's mouth and don't damage any of the structures. Don't burn his lips or don't cut his tongue on one side or don't slip with your instrument. So bone removal, Burr technique, again, cool irrigant should be used. Overheating should not be done. And bone removal should be done as planned. I'm not telling each case differs where to the bone to be removed. To create a point of application or to do a odontectomy, we plan a bone removal. Okay, use it nicely, go slow and steady, have a good assistant, nice light, good cutting instruments, good assistant, all a cooperative patient. Okay, of course, general anesthesia also being undertaken for many patients, and many do all 4 impaction under GA, which is commonly done in many centers now. Even in many of the hospitals in Calicut itself, people go for all 4 impaction under GA. It is comfortable for the patient. And a dental surgeon can train to do under GA also. If he is accustomed to that, he can do it. So debriding and smoothing the bony margins very clearly, removing all granulation tissue and bony powders and all filling pieces, everything has to be nicely removed, smoothen the bony spicule nicely and give a suture. So suturing should be done. Principles again is there, a tight suture distal to 7 that will prevent a pocket formation. Other sutures are loose, around 0.5 millimeter gap between the sutures. Not very tight because some oozing of the exudate can be sent out so that there won't be hematoma or swelling. And some people don't suture the anterior limb, leave it like that. Only you put these sutures, leave here so that the buccinator fibers hold it in position. And there is a little bit of oozing of exudate also will go through that. It will be comfortable for the patient. Swelling will be less. So complications, again, complication, I'm not elaborately going because Nair will be, Ravindran Nair will be telling about the complication area. He will touch upon that area, I think. So I'm not again repeating it. So coronectomy, nowadays, see, this is practice for deeper impaction. You avoid a complete removal when it is difficult case. Just remove the coronal portion, which is troubling you, and leave the lower 1/3 root portion. There are many articles on that. These are recent advances. There are many articles on impaction. And you can go through that. You always keep abreast with the knowledge. A lot of articles on impaction and LA and technique and instrumentation are available on the site, which you can get it in the net. Okay, and a little bit on a few slides on difficult extractions, which also I told to talk. How do you handle this? This is exclusively for the practitioner. Okay, some situation I'm just telling, too close to the maxillary antrum. You know which are the tooth which are closest to the maxillary antrum. How many minutes are remaining? Another 5 more minutes? Okay, another 5 more minutes. I'll wind up with the slides. Okay, is that okay?
Yes, sir. Fine,
Yeah,
sir.
yeah, okay. Yeah, so the tooth close to the maxillary antrum, everyone has a problem. What to do here? You know, second molar, you know, the first molar, second molar, the premolars are the nearest one, and canine, or the third molar to some extent. You every day you extract many tooth in your clinic, but you remember the maxillary sinus anatomy very well. And you know, sometimes it will be always better to take an IOPA for these tooths. It will be better to take an IOPA, which will give you you can see a lining going like that, and see the position of the sinus. Okay, tell the patient a word that this is closer to the sinus, or there is a chronic infection. There is a periapical granuloma, and if you remove, there will be no bone between sinus and the tooth. And even that breached, already there will be a little bit of breach. You take it out, there will be horizontal communication, which is going to give you trouble. So there is a chronic infection, periapical granuloma. There is a closer sinus lining. Get a consent that you may get a maxillary sinus opening. Okay, tell him in advance. And the recent X-ray will nicely tell you the thing. Because, rather than the IOPA, there will be overlapping. You will think sinus is here. Okay, it will be overlapping. So in a 2-dimensional, you can't pick it. But with a CT, of course, it is expensive and all, you can afford all the time. But an IUP is always good to look for a, the close proximity to the sinus. Because if you create a sinus opening, you have to treat it immediately. Or if it is infected, you have real trouble, you need a max pack surgeon. So always mandatory to have and see the position. And there are technique mentioned in Laskin and all. How do you extract an upper molar or a premolar when which is close to how the patient chair position. And don't press on the root, will shoot into the sinus when you do like an orange seed. These are nicely given in the textbook. Okay, always be careful. Don't try to remove the one oral communication created. Don't try to remove the tooth to that. You will never get it. Okay, don't do that. Once you have that, you tell the patient in advance. Then you displace the tooth, it is okay. And get a consent also. Then you can do a wider surgery, Caldwell loop, or refer to somebody. Otherwise, you'll have a trouble. Many cases have come to us, and we have gone to the court with many of your dental surgeons practice. It can happen with anybody, and patient will have a real problem. So oroanal communication is a very vast area. I'm not telling, this has to be kept in mind, removing upper tooth. And tuberosity area, you remove a tooth in the upper 8 area and isolated upper molar. The bony, you can see a hypercementosis or angulotic area. You use a forceps, nicely take it out. Technique, everything perfect, but a big chunk of bone comes out. Sometimes the whole tuberosity comes out. You will have severe bleeding by cutting off the greater palatine artery, and you don't know what to do. You have to pack it and hold it, and you will have trouble. So when you are applying forces, you can feel it, the entire tuberosity moving. Don't blindly pull it. If the entire thing is moving, stop your instrument. Go back and have a dissection, open up, cut the bone and take it out. Tell the patient before, there is a possibility that a big bone piece will come. And oroanal communication can also be created. So these are tricky areas. You should be very careful. Tuberosity fracture to be kept in mind. And for all implant and all the prosthetic purposes, you should never lose. Nowadays, you can't waste bone also. Hypercementosis and ankylosis look like that. You don't try to pull it with the forceps. It is not going to yield and the mandible will break. Show this X-rays and look at that. There is no cancellation here. It is dangerous. Or a fusion with other tooth, or a hypercementosis or an ankylosis. All are issues which may come even in any tooth when you're extracting. So make it a very trouble-free extraction, isolated tooth, a third molar, standing away, all alone. Be careful. The bone is weakened here. There is no 7 or 6. If 7 and 6, the mandible fracture chances are less. An isolated one, it is the hard bone. The patient has got an untreated tooth with the pan chewing. You try to hold it, the mandible may break. And the pathology there, you're going to be in trouble. Okay, and an upper isolated third one, it may produce a tuberosity fracture, more likely. And there is hypercementosis can happen. And we get it, such cases commonly in the clinic practice. You may get it, definitely. So a fractured mandible picture, you can see, the operator not see the fractured mandible. I remember 3-4 cases we had a court case in our own college. 2-3 people came from private centers and had a real trouble. And we have to fight in the court, and one person escaped. One person has to pay a big money. Okay, so this thing comes, and you cannot never send your patient with a fractured mandible without taking consent and without warning him. You remove a third molar impaction and make a mandible fracture. You're going to be a real problem, and you don't detect it and come with an osteomyelitis after 2 months. Then you are real trouble. The evidence that the X-ray speaks the thing. You don't need much of an argument in the court. So these are the things. Action, pathological condition. This is I was mentioning, a big cyst. Okay, and you can see an impaction here or a lesion there. If it is here, third molar, you don't see a big X-ray or a IOPA. An IOPA won't show this. Whole ramus is involved. You remove the impaction, the mandible will break. Malposition tooth, this will come to your clinic, removal of a canine which is palatally placed or a premolar. You will really sweat it out. It will never come out. You break it, you push the premolar out of the socket here, apply elevator here, taking support from 4 levels out. Okay, always be tricky with every extraction. Nicely plan around and elevate gently using the correct areas, holding your forceps. It is the touch and class and the expertise of the surgeon which comes by experience. Okay, and a lingual here, you put a lingual instrument here and damage the duct over here or cut the lingual artery, tooth never comes out. Okay, these are very tricky situations. Take proper X-ray plan and see, some are very, just put a small periosil and push it, it will come out. but always be careful. And I'm just mentioning the newer things. The extraction current day is shooting periotomes, always saving any amount of bone possible. That's a trend now. Periotome extraction expertise people have to take, widely used before implant surgery. Immediate implants are using periotome, and physics forceps has been introduced here. I don't know how many are using it. Sometimes we find it difficult. Maybe expertise or technical training, you can do that. Squeeze the tooth out of that. They say enzyme release comes, and you can nicely operate that. So these are the things. The current extraction is not the olden time extraction. Raising a big buccal flap and removing the whole buccal plate of bone and removing the tooth, those days are gone. You are saving each and every bit of bone to give an implant. And that is a replacement for you, which you are going to do. Remove it and putting the implant in the immediate implant thing. The scenario many are doing here, many of the practitioners, a dental surgeon can beautifully do an implant. And that is his future, immediate implant. Okay, this is going to be replacing all other forms of tooth replacement by dental surgeons. So with that thing, I always remember the time spent in preparation and planning reduces operating time. And the increases efficiency, decreases the level of stress for both the operator and the patient. So thank you very much, and thank you very much for giving me this opportunity to the IDA official bearers and keeping this program on an International Maxillofacial Surgery Day. I once again thank Sudhir and Madhavankuti and the entire team of Dynamic.
Thank you, Soumithran sir, for the detailed presentation. Now we move on to the second topic, which is about diagnosis and management of odontogenic infections. And it is by none other than Dr. Manoj Kumar, KP. He is a well-known face among maxillofacial surgeons of Malabar area. Sir is a well-known face and a consultant maxillofacial surgeon to many hospitals. Sir was the HOD of KMCT Dental College at the Department of Maxillofacial Surgery. And now sir is the principal at the same institution. Sir has performed several complex procedures with 3D prints, and he has published several papers in national and international journals. And he has also been a speaker to national and international conferences. Sir graduated from Government Dental College, Calicut in the year 1992, and he completed post-graduation in Orland Maxillofacial Surgery in the year 1997. Over to Manoj sir for the presentation on diagnosis and management of odontogenic infections.
Okay. Good afternoon, all. Am I audible?
Yes, sir. Manoj, you are
Okay.
audible.
Okay. Already, Dr. Soumithran has discussed very well on impacted tooth, very nicely presented. My next presentation, my topic of presentation is management of odontogenic infection. I think it is a relevant topic to all the general practitioners. It's the most common infection. About 70 to 80% of the all infections of head and neck. Although some of the infections being treated very easily, successfully with minimal complications, but some can transform to severe infections, life-threatening infections like deep face infections. It ranges from minimal infection like periapical osteitis to superficial or deep neck infections. Minimal infection we can manage by simple extraction or endodontic treatment. And early detection, early diagnosis, and prompt therapy is mandatory for preventing the further complications. Coming to the odontogenic infections arising from periapical infections. Some other causes are pericoronal and periodontal infections, infected cysts, and iatrogenic infections, especially while in the inferior nerve block or deeper blocks like posterior nerve block or inferior nerve block. The most important factors in the spread of infections, we can divide into general factors and local factors. General factors, these are the factors deciding whether the infection is confined to a periapical area or the progress to the alveolar bone and crossing the facial plane and finally lead to morbidity and mortality also. And another factor is the virulence of the microorganisms. Certain organisms are highly virulent. Right? They are producing hyaluronidase and fibrinolysin to lysis the fibrin and intercellular matrices and easily cross the barriers and it will lead to severe infections. Chemical factors, that is the starting from the periapical, the location of the tooth, that is the relationship of the root apex with the buccal plate or lingual plate. And first limiting factor is the periosteum. After perforation of the bone from the periapical region, infection travels towards the cortical plate and perforation of the plate. It will lead to, after perforation of the cortex, and pus will remain in the area within the periosteum, that is the periosteal abscess, and the perforating the periosteum. After perforating the periosteum, the factors, decisive factor is the host immune mechanism and the bacterial virulence. That decide whether the infection is locally limited chronic abscess or the life-threatening fast spreading the facial space infections. Then we can discuss the pathway of dental infection. We can start with the caries. Initially, the caries, enamel caries, then extend to dental caries, and finally invade to the pulp. That will lead to pulpal. If the pulp is exposed, that is the constant contact with the skin factors like chemical or thermal irritations, that will lead to inflammation of the pulp and inflammation of the pulp that will lead to acute pulpitis. That is the patient having severe pain. That condition, the patient reported with the severe pain. Usually in general practice, we are all giving antibiotics and analgesics. That is not a right way. In acute pulpitis, just open the access cavity and releasing the pulpal pressure, decompress the area that will get released to the patient, and also can give the analgesics. And don't use any antibiotic cases. Then acute pulpitis, next, if it is untreated, that will lead to increase the intrapulpal pressure, that is, pulp is confined to the root canal There is a narrow space. There is a small space, the apical foramen. That is within the, that increase the intrapulpal pressure that will lead to the venous congestion and avascular necrosis. That will lead to finally pulp necrosis occur. Any necrotic material, usually it is invaded by the microbial organism and this immune mechanism there that will lead to pus formation. And this pus gradually, the periodic ingress of bacteria to surrounding alveolar bone that will reach the periapical region, that is root is situated in the narrow space. And there are two cortical plates, buccal cortical plate and lingual cortical plate. From the first stage, that is the periapical abscess, that is pus is confined to the periapical region. Usually patient complains of the tooth is slightly extruded and pain on biting and tender on percussion, and X-ray shows certain rarefaction in the periapical area. That is called periapical abscess. In such cases, if the tooth is unrestorable, we can go for extraction of the tooth, or if it is restorable, go for endodontic therapy. Initially, we open the access cavity and releasing the pus and give the antibiotic. When you are giving the antibiotic, that is called empirical antibiotic therapy. Empirical antibiotic therapy means those antibiotics that is sensitive to the susceptible organisms in the area. Then you should know which are the organisms commonly involved in the Endogenic infection. Then only you can give the proper antibiotic. Actually, the proper antibiotic, the penicillin is the drug of choice. That we'll discuss later. These are the microbiology of oral cavity. We have sufficient time to discuss everything. So just go to that. The main streptococci. And initial stage of infection, the most of 90% of the infection is aerobic. As the infection advances, the more anaerobic organisms. So when you are giving the antibiotic, initial stage, you have to give the penicillin derivative or first generation or second generation cephalosporin. As the infection advances in the abscess stage, you have to give the anaerobic drugs used for anaerobic, that is the metronidazole or clindamycin, etc. The stage of infection is very important in the diagnosis. The management depends upon the infection. First stage is the inoculation, that is edema only. That means initially periapical abscess is there. There is no clinical signs, but after perforation, there is edema in the buccal vestibule or labial vestibule. You can see that is second stage is the cellulitis. Cellulitis, it is a diffuse swelling and duffy consistency. You can't take fluctuancy, and patient having sometimes fever, rise in temperature, erythema. These are signs, and there is no fluctuancy. If it is seen in the buccal or labial vestibule, when palpate, you can feel the obliteration of the labial or buccal vestibule. That means some fluid is there. There is no suppuration. Suppuration the late stage, that is called abscess. If it is untreated, it's not properly treated, it will become localized, and suppuration of that area, that is called abscess. Finally, the resolution. If the abscess is not treated, that will lead to sinus tract, this break open, and sinus tract formation. That is the chronic abscess. That is the difference between acute abscess and chronic abscess. You can differentiate the cellulitis, not a correct way. Cellulitis in some of the area looks like abscess. Actually, it's a glistening area where diffuse swelling, there won't be any fluctuation. And how do you identify an abscess location, focus or foci of infection? From the location of the swelling, that is abscess, we can identify, we can predict from which teeth infection occurs. For example, can briefly describe maxillary teeth, maxillary incisors, maxillary central incisor and lateral incisor. I have already said the periapical from the periapical infection. First is traversing either towards the buccal cortex or lingual cortex or buccal cortex or palatal cortex. That based on the proximity of the root to the cortex. Usually the maxillary incisors, the infection was traversing towards the labial cortex and perforation of the labial cortex, and pus will comes out from the labial cortex and collected in between the periosteum and the cortex, that is called subperiosteal abscess, and finally perforation of the periosteum and collection of pus in the labial vestibule. You can diagnose easily by palpating from the opposite side by using the finger palpation, and in the anterior region you can see that the depth of vestibule is obliterated. That means some collection of fluid. It can be cellulitis or abscess. Abscess, when you palpate by two fingers, can move the, you can elicit the fluctuation. Okay, from central incisor, collection, localization of pus in the labial vestibule. From lateral incisor, there are 50-50 chances. Some of the cases, the 50% chances for localization in the labial vestibule, 50% chances in the palatal abscess. When you see palatal abscess, you should look for the lateral incisor, whether it is non-vital or not. Sometimes it may be non-vital due to past history of trauma or deep cavity filled with the composite respiration or fracture tooth. Sometimes you can't see any caries, previous history of composite respiration, the deep cavity. Then next, third one is the mandibular maxillary canine. But peculiarity of canine is long root. So when there is perforation of the buccal labial cortex, the perforation is above the muscles, superior labius superioris and like nasi. So pus is collected in between the skin and the lateral wall of nose, that is called canine space abscess. If you see the canine space abscess, you look for the canine is non-vital or not. Then next is the premolars. Premolars, the maxillary premolars. The peculiarity of maxillary premolar, first premolar has buccal and palatal root. So there are two chances of localization, either collection of pus in the buccal vestibule or collection of pus in the palatal abscess, that is palatal abscess from the palatal root of the first premolar. Then next, second premolar infection usually localized in the buccal vestibule. Posterior teeth, posterior maxillary teeth, that is the molar, first molar, second molar, and third molar. There are two chances of localization. One is either localized in the buccal vestibule or it is enter into the buccal space. That is decided by the perforation of the buccal cortical plate. Pus is traversing towards the buccal cortex and perforation of the buccal cortex. If the perforation of the buccal cortex is the origin of buccinator muscle, above the buccinator muscle, it will enter into the buccal space, that is with the collection of pus in between the skin, subcutaneous tissue and the buccinator. And clinically, it appears as the dome-shaped swelling extending on the cheek. There is a swelling in the cheek that extending from the corner of mouth and the anterior border of the masseter muscle. That is, you look for if there is any swelling in the buccal space, that is dome-shaped swelling in the cheek, you should look for the infection from maxillary molars or mandibular molars. Maxillary or mandibular molars. So the location of the swelling, we can decide, we can predict the infection, we can predict the foci of infection. Then next is the primary site of localization from the mandibular teeth. Mandibular teeth, the mandibular incisors, central incisors and lateral incisors, usually perforation of the labial cortex that will lead to collection of pus in the labial vestibule, swelling in the labial vestibule. In the premolar region, there are two chances. One is 50% chance for perforation of the buccal cortex. If it is perforation of the buccal cortex or labial cortex, collection of pus in the labial vestibule. If it is perforation in the lingual cortex, there are two chances from the root apex. Root is situated in the cancellous bone, and there are two cortical planes. Either it travels towards the lingual cortex or buccal cortex, and perforation of the lingual cortex, that usually the pus is collected in the sublingual space. That is, you can see intraoral swelling. The floor of mouth is elevated, and you can palpate the swelling. If it is buccally perforated, the pus is collected in the labial vestibule, that is vestibular space abscess. From the molars, mandibular molars, first molar, second molar, third molar, that is the factors decisive. There are 50% chances for the buccal cortex perforation, 50% chances for lingual cortex perforation. If it is lingual cortex perforation, the factor decisive is the muscle attachment, that is the mylohyoid muscle. You can see the mylohyoid muscle is situated, its origin is situated higher in the posterior region, third molar region, and as it goes anteriorly, your attachment is towards the lower border. So, from the infection from the first molar, mandibular first molar, if the pus is traversing from the root apex towards the lingual cortex, that will lead to perforation of the lingual cortex. So, that is almost always above the mylohyoid muscle, that is localization of pus in the sublingual space. Then, if second molar and third molar region, if the pus is traversing towards the lingual cortex, there are from the second molar, there are 50-50 chances. If the root apex is below the mylohyoid line, it is entering into the submandibular space. If it is above the mylohyoid line, it is localized in the sublingual space. Sublingual space, intraorally, you can see the swelling in the floor of the mouth. Submandibular space, the swelling in submandibular triangle. So, if there is any submandibular swelling, you should suspect the foci of infection is either mandibular second molar or mandibular third molar, the foci of infection. So that is very important. You should know in diagnosis, you should know the stage of infection, which are the spaces get infected, everything you should know. The first picture is the canine space infection, that is arising from the canine tooth. Second is the buccal space infection. You should have has to differentiate the buccal space infection and submassive space infection. Submassive space infection is the swelling is confined to the anterior, in between the anterior and posterior border of the masseter muscle. That is, the buccal space is situated in between the corner of mouth and posteriorly it extends to anterior border of the masseter. So, if there is a buccal space infection, should look for whether the maxillary or mandibular molars is any have to rule out any focus of infection. Infratemporal space infection arises mainly from maxillary posteriors. Submental space infection arises from the mandibular anterior teeth. Sometimes it may localize intraorally, that is the vestibular space abscess. If the perforation is below the attachment of the mendalis muscle, it will enter into the submental space, that is called a submental space abscess. Sublingual space, then submandibular space. Suppose the patient reported to your clinic with trismus. You should look for 3 spaces, that is pterygomandibular space, submandibular space, and temporal space. Pterygomandibular space is very familiar to you. When you are giving the inferior nerve block, you are depositing the solution in the pterygomandibular space. Actually, there is no space. The spaces are formed by the collection of any inflammatory fluid or pus in between the muscle and the bone. It is a potential space. Actually, there is no space. The invasiveness of the microorganisms penetrate the area. They are secreting the fibrinolysin and hyaluronidase, breaking down the area and entering into the muscle and bone, and collection of pus, then it forms a space. The pterygomandibular space in your general practice, if the needle is contaminated, should be very careful when you are giving the block, inferior nerve block or posterior nerve block, without just before giving the injection to remove the cap. Otherwise, when you touch the needle, we are introducing the microorganism into the deep space, pterygomandibular space. From the pterygomandibular space, infection may spread to the lateral pharyngeal space, parapharyngeal space, that may enter into the mediastinum, so it will become severe fatal infections. So pterygomandibular space is very important. The patient reported with the trismus, and there is no extraoral swelling, sometimes minimal swelling in the middle aspect, but most of the cases, swelling is situated on the medial aspect of the ramus, that is the coronoid anterior border of the ramus, that's medial to the anterior border of the ramus. You can see the swelling extends to the posterior palatal region, soft palatal region, uvula is deviated, okay. That is the pterygomandibular space. Submacetic space, not much visible swelling, but there is a diffuse swelling on the masseter muscle region and patient having trismus. Usually, the submacetic space infection and pterygomandibular space infection arises from the third molars, impacted tooth, and that is due to the direction of the root is either laterally towards the ramus, it will enter into the submacetic space. If it is medially rotated, the infection may spread to the pterygomandibular space, or from the submandibular space. If untreated, it may extend to the pterygomandibular space, or all the spaces are contiguous. We have divided the spaces into primary spaces and secondary spaces. Primary spaces means the spaces with a direct continuity with the bone, alveolar bone. That is the first entering space is called primary space. If it is untreated, it will extend from one space to another space, that is the secondary space. Secondary spaces are mainly the masticatory spaces and pharyngeal spaces. Temporal space is the submacetic space. Pterygomandibular space infection, extraorally no swelling, tenderness and swelling over middle aspect of anterior border of ramus. Patient having dysphagia, midline of palate is displaced to unaffected side, uvula become swollen, difficulty in breathing. Temporal space infection usually arises from the third infection or from the pterygomandibular space infection ascending to the infratemporal space, from the infratemporal space to temporal space infection. Usually seen in the swelling in the temporal region and patient having trismus. One of the most common complication of infection is Ludwig's angina. When you have a patient with swelling, is swelling in the neck region, it is swelling, it's a cellulitis, the board-like swelling involving bilateral submandibular space, bilateral sublingual space, and submental space. If the swelling crossing the midline, we can consider turn to be a Ludwig's angina. It is a serious complication. Usually, the clinical features is patient looks toxic, very ill, dehydrated, pyrexia, anorexia, and impaired speech and hoarseness of voice. and swelling is non-pitting, non-flexion. It's not an abscess. It's ill-defined borders with induration. Patient having trismus and edema, and the tongue is elevated and touching the palatal valve. Airway obstruction, increased respiratory rate and shallow breathing. Fatal, sometimes it may lead to death also if not properly treated. Coming to the principle of management of maxillofacial infection, I have already said we can start from the minimal infection like periapical infections. Acute pulpitis, there is no infection, antibiotics is not required, just open the abscess cavity, releasing the inflammatory fluid, that's it, that's all. And giving the painkillers. You don't use any unnecessary antibiotics. Is there? Sterile, not any organisms. So next is the periapical abscess or periapical osteitis. Periapical abscess, if the tooth is not restorable, you can go for extraction of the offending tooth or go for endodontic therapy. Endodontic therapy open the abscess cavity and releasing the pus and give the proper antibiotic. The main thing is that determine the severity of infection. For that, you have to take proper history. Proper history means you have to take a medical history, whether the patient is immunologically compromised or not, the alcoholic, uremic patient, severe diabetic, patient having any history of the malignancy, any history of cytotoxic drug therapy or the anti-steroid therapy. That is very important. The patient's immune status should be identified. And suppose there are two cases. One case with a single day and with a huge swelling and patient having fever, toxic symptoms. That is a very severe condition. So you have to refer the patient immediately. Otherwise, it may lead to either the patient's immune mechanism is compromised or the microorganism is highly virulent. These are the two possibilities. So it may lead to a fastly spread and affecting the secondary spaces and sometimes lead to morbidity and mortality. So better to refer the patient immediately. Evaluate the host defense mechanism. Decide on the setting of care. What is setting of care? Whether we can treat it OP basis or admit the patient. Okay. Then treat surgically. Which are the cases treat surgically? In case of cellulitis, medical treatment is sufficient. Medical treatment means start the empirical antibiotic therapy. Empirical antibiotic therapy means those antibiotics, you have to prescribe the antibiotics sensitive to the susceptible organisms. That is evidence-based or from literature. These are the organisms commonly involved in the odontogenic infection. You have to give that antibiotic one. Those antibiotics sensitive to the otherwise they will generate the drug resistance. Then, in case of abscess, you have to drain the abscess, incision and drainage. That's very important. What is the objectives? The objective of the IND is to get rid of the toxic material from the abscess cavity and decompress the tissue and the increase the perfusion so that the antibiotics and immunological elements can reach the area, so that otherwise when you give the antibiotic without drainage, that will lead to antibioma. That means we will not reach the central area. The central area become necrotic due to lack of blood supply. So as early as possible, you have to decompress the area by incision drainage. I have to place the drain, allow to drain the pus. Otherwise, it may lead to that is the proper way of treatment. The knife is the best medicine for treating the abscess. Support medically proper nutrition, vitamins, and the analgesics and antibiotics. Then choose prescribed antibiotic therapy, least toxic but narrow spectrum antibiotic. Prefer the bactericidal, and dosage also is very important. You have to, for example, when you are giving the augmentin, amoxicillin, clavulanic acid, you have to give the most of the prescription you can see that BD, 12th hourly. That's not a correct way. You have to give 8th hourly. There are MIs, minimal inhibitory concentrations there. So you have to give, you are giving the antibiotics, amoxicillin, clavulanate acid combination, have to give thrice daily for minimum 5 days. Minimum, not 5 days, minimum 5 days. Then choose and prescribe the antibiotic therapy. The antibiotics effective in odontogenic infection is drug of choice is definitely we can say that penicillin. Second is amoxicillin clavulanate combination. Then cephalosporin, you can use the first generation and second generation, that is cephalexin, cefixime, cefuroxime, and the third generation is not effective. It's more prone to the gram-negative organisms. Administer the antibiotic properly, evaluate the patient properly. These are the factors associated with the immune system compromise. Criteria for hospital admission: temperature more than 38 degrees, patient is dehydrated, patient having toxic symptoms, that is shivering and anorexia, chills. Then threat to airway, to vital structures, infection, moderate, highly severity of anatomic spaces, need for general anesthesia. You are commonly using the Hilton's method of incision. How do you incision drainage? The principles of incision drainage is you have to incise. First, you have to palpate the area intraorally, vestibular abscess, palpate, and you have to nick the area on the most dependent portion and the most fluctuant portion, and by using the number 11 blade, and introduce the sinus forceps and dilate the blade and allow it to drain out. If it is available, better to take the swab and send the pus for culture and sensitivity test. That is the proper way. First, you give the empirical antibiotic therapy, then take the pus for and send the pus for culture and sensitivity test. After 48 hours, we get the result of culture and sensitivity test. And if the antibiotic you have already prescribed is matching with the culture and sensitivity test, you can continue. Otherwise, you have to change the antibiotic according to culture and sensitivity test. And when you're doing the IND, you have to intraorally you can place a gauze rod and suture that. Extraorally, you can do the rubber drain and secure the drain with the skin by using sutures. Keep the drain for till the pus discharge is stopped. So, vestibular space abscess, you have to drain easily and drain out the pus and can place the submental space abscess. The most usually in skin incision, we are giving the incision on the healthy skin, not the central. If you are putting incision the central portion, that will lead to anesthetic ulceration. So you have to place in the dependent area, that is the lowermost area, and in the healthy skin, you have to consider the anatomical structures when placing the incision, and also aesthetics also. Langer's parallel to the Langer's line. This is the support medically. Supportive measures include hydration, improved nutrition, pain control, and antibiotic therapy. Very particular that in the early stage of infection, you can do that amoxicillin clavulanate is sufficient. But according to theory, you have to use the narrow spectrum, but it is very, we are taking risk. If the patient is medically compromised, better to give the broad spectrum antibiotic. In the end stage of the lesion, end stage of the abscess infection, you have to give the amoxicillin along with the imidazole derivative like metronidazole or tinidazole. These are the antibiotic of choice. Outpatient can be penicillin, clindamycin, cephalexin, cefixime, cefuroxime. If the patient is facing allergy, you can give gentamicin, moxifloxacin. The ciprofloxacin is not much effective with the odontogenic infection. There are certain combinations that ciprofloxacin tinidazole combination. Ciprofloxacin is mainly for gram-negative infection. When you are using antibiotics, administer antibiotic properly, proper dose, proper timing, duration of administration, and typical regimen is 4 to 5 days minimum 4 to 5 days. And evaluate the patient frequently. Typical follow-up period is 2 to 3 days after surgical treatment. Your infection management is completed after complete, if the abscess is drained out the abscess and proper antibiotic to remove the focus infection. If the tooth is restorable, you can go for endodontic therapy. Then only the completing the treatment of infection. To conclude, the odontogenic infection may range from low-grade, well-localized infection that require only minimal treatment to severe life-threatening deep facial space infection. Although majority of the infection can be managed easily by minimal surgical procedures like extraction or minimal INT and supportive medical therapy, sometimes must constantly bear in mind that this infection occasionally becomes severe and life-threatening in a short time, so should be special care. Thank you. Then I extend my special thanks to IDA Malabar Branch organizing team, especially Dr. Sudhir, Dr. Madhav, and also the hello, and for the opportunity and communication, CD convener communication, and also Dr. Sameera. Okay, thank you, and wish you a happy first day to all.
Thank you, Manoj sir, for explaining the diagnosis and management of odontogenic infections. The next topic for the day is about procedural complications in dental practice, and it is by none other than Dr. Ravindran Nair. Sir completed his BDS from Government Dental College, Thiruvananthapuram in the year 1987, and sir went on to take maxillofacial surgery as a specialty from Punjab Government Dental College, Amritsar in the year 1990. He is also a fellow of the Indian Board of Oral and Maxillofacial Surgeons. Sir is into teaching since September 1996. Sir is currently the chairman of Indian Board of Oral and Maxillofacial Surgeons. He is also a national executive member of AOMSI. He has been the president of the Kerala chapter of AOMSI and has held various positions in the organization. Sir has been the president of IDA Malabar branch in the year 2011. He was also the charter president of IDA Alappuzha branch in the year 2000-2001. Sir is the member of the academic council of the Kerala University of Health Sciences in the year 2016 till 2019. Sir has also served several positions at various universities. For example, the Kannur University, the Calicut University as a member of Board of Studies in the PG and UG sessions. And sir has delivered the NS Rajivan oration at Mahi in the AOMSI State Conference in the year 2014. He has been an invited faculty to many CDs and conferences, and he has chaired sessions in IDA, AOMSI conferences, and has also authored multiple articles in the international, national, and state journals. Over to Ravindran Nair, sir, for the procedural complications associated in dental practice. Thank you.
Thank you, Sameera. Good afternoon. There is one correction in what Sameera said. I am a past chairman of Indian Board of Maxillofacial Surgery and not the present chairman. And I have been talking about complications, emergencies, trying to spare the people for a long time. And our new president some time back told me that he has clinic tomorrow and better not spare him. We want to do extraction tomorrow. So as per his request, I thought that I will limit the topic to things, complications which develop, which can be easily preventable complications only. So while going into the preventable complications, it is, if you can read this article by a famous author, Peter Brannan, who says that how does this errors occur in the surgery? So most of these are human errors. The one is due to improper training. That means after passing out, all of you have to get trained regularly and continuously to prevent these sort of complications developing. Along with that, you have some personal factors which can be confined as fault. That means hungry, angry, late, or tired. And similarly, personal factors like dehydration, multitasking, poor communication, or leadership, loss of situational awareness. It is a very important thing. If you lose the track of time while doing a longer procedure, there is every possibility that you could possibly end up in a complication. The human errors again is tabulated as tiredness, lack of nutrition or hydration, or improper nutrition or hydration, emotional factors, effective communication, challenging authority. That means especially if in a large hospital sort of thing where you have a steep hierarchy. And the most important factor is the situational awareness. Situational awareness can be said as knowledge of what is happened during the procedure, what is happening now, and what might happen in the immediate future. So Dr. Brennan has given a series of ways by which possibly an adverse event can happen. Here he has put a picture showing how a adverse event like a wrong side surgery can. If anybody has seen Swiss cheese, you know that it has got multiple holes and none of the holes are in straight lines. Then aligned together, you are going to definitely have an adverse event. Now, coming to the procedural complications proper. Intraoperatively, you can have soft tissue injuries, hard tissue injuries to the tooth which you are planning to remove, tooth adjacent to, or even fracture of the bone. And you can also expect to have postoperative complications. Now, coming to the soft tissue injuries, the first soft tissue injury, which usually mostly see, is mucosal tears. While you are putting an incision, or while you are elevating the mucoperiosteal flap, because of the improper surgical technique or handling of instruments or use of uncontrolled force, there is every possibility that an unwanted tear can occur. Actually, how do you prevent it? You make sure that you use the instrument as it is intended to, and always support the soft tissue while reflecting the flap, and make sure that the forces you apply are controlled. Well, what happens if it is occurs? You need to cross the tear. Another complication, procedural complication, which almost all of you might have seen, is punctures occurring due to slipping of instrument. This instrument can be straight elevator or a periosteal elevator. The common sites are usually the posterior palate, and they're preventable if you use controlled force. And another way is to make sure that you have your index finger of the opposite hand to support and to act as a stop. If you have your finger just beneath the, just adjacent to the elevator, you'll be very careful, because if it slips, it's going to hit your finger and not the patient's oral cavity. What will happen if the puncture occurs? Usually it can be allowed to heal by second injection. Now, cuts and lacerations also occurs basically because of carelessness only. Just basically seen in the lips and cheeks. And one of the reason is lack of alertness or lack of not being present. A surgeon, when doing a procedure, especially when there is no space for complacency, you need to make sure that when you are using the sharp instrument, it has to be supported properly, and the incision or whatever thing you are planning has to be done as per the plan in your mind. Now, what are you going to do with these lacerations? Depending upon the shallow, wound can be left alone. Now, avulsion and avulsion injuries. Abrasion and avulsion injuries. This is basically common in the seen in the lip, cheek, and the corners of the mouth. This is basically seen when you are using long shank rotary instruments, and also due to rubbing into the soft tissues, repeated rubbing into the soft tissues. These are the reasons for usually developing of the abrasion. And what you have to think is that you have to ensure that there is adequate interaction and the protection of the tissues while you are using non-rotary instruments. It is usually conservatively managed. The area can be covered with Vaseline or anesthetic gel, but sometimes it might produce an at least, especially in the corner of the mouth. Probably you might have to think of a revision at least later. Crutch injury is also very common in the, especially while using upper molar forceps. Upper and lower lips are in danger, and lower molar forceps, the lower lip is in danger. That is basically because of the careless insertion of the beaks, the gingiva gets crushed. You have to be very alert when you apply the beaks of the forceps. The beaks of the forceps, fulcrum area, and the handle are the areas which will lead to crush injury. The gingiva is properly elevated. Another thing which might usually occur is surgical emphysema. That is because of the use of aorta to do the bone or the tooth suctioning. The important thing is never to use the aorta for these purposes. That will prevent this. But suppose it occurs, you have to make sure that you inform the patient, because the patient will suddenly see a reasonably good swelling on the face. Usually the absorption is spontaneous. The only thing is that there is a possibility of infection. So probably you may have to put the patient on a course of antibiotics. Thermal injury is also very common in the lips, cheeks, and the angle of mouth. Usually because of the hot instrument taken from the autoclave or the sterilizer. The operator hand usually is gloved, wet, and the operator may not sense it. Still more possibility is because of the overheating of the rotary instruments. How it can be prevented is by making sure that the instruments are cool, or you dip the instrument into cold saline before using it, and make sure that you will maintain the rotary instruments properly, and also make sure that you will retract and protect the soft tissues very well during the use of these instruments. Basically, you can apply Vaseline or pain relieving gel once the thermal injuries occurs, but only issue is that it may leave an ugly scar for a long time. Hematoma or ecchymosis also can occur, especially in the chin region, that occurs due to mild internal bleeding. All you have to do is to reassure the patient, apply the cold compress immediately. Hot packs can be given later. The possibility of infection is there, so probably a course of antibiotic might be in order. Now, coming to the injuries to the tooth and bone, the soft tissue part is over. The injuries to the tooth and bone. The most common complication which can occur is fracture of the tooth or tooth roots. Basically, because of the improper technique, or due to improper elevation, improper application of forceps, improper instrumentation, and use of excessive force. The other possibilities are the tooth was inherently weakened, or due to abnormal morphology, or due to dense alveolar bone, or you are being hasty in doing the procedure. All you have to do is to make sure that you do the correct pre-planning and assessment, correct usage of instruments, use of controlled forces. Ideally, any roots left behind are better removed. But can you leave the roots behind? If the roots are vital root less than 5 mm, or a root tip can be left in situ in a normally a healthy person. But if the particular root is infected, you better remove it. If it is already luxated or mobile, then you have to remove it. And if the patient is immunocompromised, it definitely has to be removed. The dictum in this case is you have to assess the risk versus benefits, because trying to remove the particular tooth or the tooth root is going to cause a lot of damage to the soft tissue, and maybe the patient is not very healthy, or the patient is apprehensive, not cooperating, then probably it can be left alone. But the only important thing is that the patient has definitely to be informed, and it must be entered in the case report that you have left behind the particular part of the tooth and you have informed the patient. Now the tooth or the tooth root can be displaced into different parts. It can very easily disappear from the expansion socket. Probably it might have gone into under the mucoperiosteal flap, in which case if you palpate, you might be able to feel it. If it is there, you can put a small separate incision on the mucoperiosteum where the tooth is felt, and you can then remove it. It can also go into the lingual pouch. In the lingual pouch, only thing is that unless you fix the tooth piece with the finger, it can get displaced into more deeper areas. So make sure that you fix the root piece with your hand and then put a small incision in that region, and you can very easily remove it. It can also go into mandibular space. It's not very common because it has to go below the mylohyoid muscle to reach them. I don't think it can be very easily explored and removed. I think it will be better to refer to such cases. The tooth or root can easily get displaced into the pterygopenetrant floss, especially the highly placed third molar with a conical root. And if you are using the forceps or not engaging the forceps properly, or due to carelessness, it can very easily slip through the thin alveolar bone into the pterygopenetrant fossa. In which case, it is difficult to identify and remove, and I think it will be better for you to refer the case. The root of the tooth can also be displaced into the maxillary sinus, especially common with premolars and second molars, and those with the conical roots, in which case you can identify it with radiographs, explore and remove if possible, and if you find it too difficult, you refer the case. Aspiration. This can only occur due to carelessness, because when you are doing an extraction of such things have to be in control, but sometimes it happens. Generally, it gets swallowed. Very rarely it goes into the tracheobronchial tree. If it goes into the tracheobronchial tree, the removal is going to be very difficult. If it gets swallowed, nothing will happen. But if it goes into the trachea, then actually it is beyond our hand. We have to refer the patient to a thoracic surgeon or a pulmonologist, and probably it will require bronchoscopy for the removal of the tooth or tooth root. Now coming to the injuries to the teeth and bone of the adjacent tooth, not the tooth you are planning to remove. Basically, three things can occur. That is subluxation, luxation, or fracture. Basically, this occurs due to the improper use of elevators, forceps, or due to excessive force. But to make sure that you will use the elevators properly, ensure the elevator or the forceps is resting on the adjacent tooth. And you may have to make sure that you will stabilize the adjacent tooth while you are doing the elevation. If it is luxated, you have to make sure that you fix the tooth, stabilize the tooth, probably do occlusal grinding and take it out of the occlusion so that it will heal properly. If it is avulsed, we need to reimplant it as early as possible. And the patient has to be informed of the possible need for endodontic treatment, and the same has to be entered into their case reports. Fracture of tusks, restorations, crown, etc. This should be prevented. This you have to be very careful. You have to do the proper preoperative planning and evaluation. And if this occurs, you have to repair or refix as is required. Extraction of the wrong tooth. Well, it is carelessness and it's inexplicable. One possibility is that improper communication from the check. This is the same tooth you are extracting. Recheck and check again if necessary. And if in doubt, if it is a referred case, you better communicate with the referring doctor and then only do the extraction. And suppose you have extracted a wrong tooth, you have to reimplant it immediately, and the need for endodontic therapy has to be emphasized, and that has to be recorded in your case sheet. Now, fracture of the maxillary alveolus can occur in an older patient, especially if you place the instruments improperly and use excessive force and you are being hasty. Very easily the fracture of the maxillary alveolus can occur. Whenever a single tooth is there in the maxillary alveolus and the rest of the maxillary alveolus is resolved, there is every possibility that the bone, the tooth and the rest of the bone will come out together. So when you are removing that, you have to make sure that you will adequately support the bone while doing the extraction. This can be very done by identified by preoperative assessment, and also by making sure that you will always support the alveolus during your procedure. Injuries to the teeth and bone, it can occur with the maxillary alveoli. Bone can be completely detached. If that is the case, it can be removed with the along with the tooth. But if there is reasonable bone and soft tissue cover, you can attempt to detach the tooth from the bone and then support the fractured alveolus and reposition the flap tightly. Make sure that the complete tight closure is obtained so that whatever the remaining bone, which has got a reasonable mucoperiosteal attachment, remains as tight as possible. The fractured maxillary tuberosity can occur, especially when you are trying for extraction of maxillary second or third molars. This usually happens due to the use of excessive force. Make sure that you do preoperative assessment and support both buccally and palatally while elevating and also applying the forceps. Suppose the maxillary tuberosity fracture occurs, if it is a small fragment, it can be very safely removed. Prosthodontists will not agree with it because that is going to cause problem with the denture at a later time if at all becomes necessary. But this is a large fragment. You have to remove the tooth surgically and then achieve tight closure and keep the bone back into the site. You can leave the tooth or splint it as an alternative and go and remove the tooth at a later time surgically. In all these cases, you have to think that there is sinus involvement and manage it as a sinus involvement by doing a tight closure and always following the sinus regime. Fracture mandible. This is not at all acceptable in normal routine cases, but it can occur in deep induction or in persons with atrophic mandible, elderly people having presence of cyst or tumors. The basic thing is you have to do preoperatively assess the patient and possibly think that this is a person where the fracture mandible is possible. And if it all occurs, the only way to do is you have to go and reduce and fix it. In such case, you have to inform the patient, record, and inform your representative also. Other complications like breakage of instruments can occur like elevated tips, burrs, drills, excessive force, fault in manufacturing, overused instruments. These are the reasons usually this occurs. All old overused instruments are better thrown away. And suppose this occurs and it gets displaced into any of the spaces, you can take radiographs, debride and attempt to remove it. If unsuccessful and if it is in a deeper plane, I think it will be better to refer the case. Complications to TMJ can occur. The soft tissue complications like trauma to the capsule occur due to the inadequate stabilization of the mandible during extraction. The mandible has to be stabilized properly during the extraction of the lower teeth. Suppose a concussion to the TMJ occurs, it can lead to postoperative pain, limitation of movement. If these things occur, usually all you require is conservative management. Usually that will go by itself. And it's a possibility that you can have dislocation due to the excessive force and also failure to support the mandible. You have to make sure that during your case taking, you identify whether the patient had previous history of dislocation. And if dislocation occurs, you have to do manual reduction. And if the patient had a history of dislocation, you can plan for extraoral bandage. Other complications like oroantral communication or oroantral fistula can also occur during the extraction of tooth related to the sinus. You have to make sure that you preoperatively assess the tooth and probably plan for such a eventuality. If anything is small, like 2 mm or a puncture, usually it will heal by itself because blood clot will come there and it will block the communication, and usually it will heal by itself. Usually, antral regimen need to be followed. If it is anything more than 2 mm, usually the clot will not remain there because while you breathe, the pressure in the antrum increases and usually the clot will not remain there. In such case, what you can do is a surgical closure. You can take a flap, either buccal flap or palatal flap. If you have the technicality to take the flap, you can do it and close it immediately. If you can close it immediately, that is the best. And if you leave it and it becomes an oroantral fistula, it becomes a more difficult problem, and then you will have to refer the case. Bony spicules can remain after extraction. This is also due to improper debridement. In this, the debridement, what I mean is that after extraction, each extraction, you have to make sure that you inspect the site of your surgical site, that is the extracted site, look into the socket. If there is any bony spicule or even calculus, something like that, you have to make sure that you debride that area properly, and only after that, you should send the patient. If bony spicule is found on inspection, you have to make sure that you remove or file the sharp bony spicule. Postoperative complications like nerve injuries can occur to inferior alveolar nerve, lingual nerve, and mental nerve. Dr. Soumithran mentioned that the lingual nerve is very close to the third molar region. So while planning for extraction of the third molar region, especially while you are raising the medial flap or the lingual flap, you have to make sure that you will remain under the mucoperiosteum or remain close to the bone. The mucoperiosteum is your protection against the injury to the lingual nerve, which is always outside the mucoperiosteum. So if you are inside the mucoperiosteum, very unlikely that you will cause injury to the lingual nerve. The mental nerve injury usually occurs when you are doing a vertical incision for episectomy or such procedures, and sometimes you do incomplete releasing incision, and while elevating, while retracting the flap, you will use excessive force. You will have the retracting elevator compressing on the mental nerve region, which can also lead to temporary paralysis of the mental nerve. And sometimes we plan to remove the bone from the mental nerve region, probably to remove the root of the broken lower 4 or 5. Even then, the mental nerve is in danger. There is a possibility that traumatic arthritis can occur because of the excessive force used and the prolonged procedures on unsupported mandible. This can be easily prevented by making sure that you will will not use excessive force. You will support the mandible always. And if it happens, you can always ask the patient to rest the joint, and analgesics and anti-inflammatory can be prescribed depending upon the need. Acute osteomyelitis also can follow a dental extraction, even though it is not very common. Commonly in immunologically compromised patient and in the surgery in the presence of infection. So before doing an extraction, all the textbook advise that you have to do scaling, because any acute gingivitis, periodontitis, pericarditis present there, while you are reflecting the flap, you are actually inserting the organisms into the deeper plane. So even though we do not do it, but ideally, if you do the scaling or if you remove the calculus, whatever is present before doing the extraction, you can prevent a severe complication like osteomyelitis or even displacement of calculus into the extracted socket. The last you can say is the failure to complete the procedure. The failure to complete the procedure can be due to the inadequacy of the anesthesia, which could be due to faulty technique or it could be due to insufficient dosage. It could be due to the lack of cooperation of the patient. It could be due to the lack of facilities of the in your clinic. And lastly, due to the lack of skills. And none of these things I have got on my mind and prepared. This is basically taken from the textbook of Orland Maxillofacial Surgery, written by Neelima and Ilmari, 2nd edition. And I thank each and everyone for patiently listening, and thank IDA Malabar for giving this opportunity to present these complications to you all, and wish you all a happy International Awareness Day. Thank you.
Thank you, Nair sir, for the explicit explanation on the complications related to the procedures. Now we are moving on to the question answer sessions. If the audience has got any queries to ask, you can ask in the chat box. I hope Soumithran sir is available.
Yes, I'm here. I'm here. Can you see me?
Soumithran sir.
Yes, I'm here. No.
Thank you, sir, for being available. The first question we have is, how can we manage trismus following impacted tooth removal?
Okay, is that question to me or Nair? I think Nair can take that. Ravindran Nair, please.
What is the question again?
Sir, how can we manage trismus following impacted tooth removal?
Trismus can actually occur due to different reasons. The one is actually due to the injection. The second could be due to the excessive force. So what you have to identify is that how fast the trismus occurred. If the trismus had occurred immediately, it could be due to the needle hitting an artery and causing bleeding into the ergomandibular space, causing spasm to the muscle there and leading to trismus. That is usually immediate. And sometimes if the patient is has opened the mouth for a long time and you have done extraction by not properly supporting the mandible, there is every possibility that the patient might develop traumatic arthritis, which can also lead to decreased mouth opening, which can be called it as trismus. And thirdly, if the trismus occurs following after a few days with swelling and rise of temperature in that region, it could be due to a secondary infection occurring there. Then these are the three different scenarios, and according to each scenario, the management will differ. Because in the first case, it is due to bleeding. It is due to bleeding following the injury to the artery. So once the blood gets absorbed from the site, usually it will go away by itself. So probably because there is muscle spasm, you can prescribe drugs which will prevent reduce the muscle spasm. In the second case, where there is a possible concussion of the TMJ, what you can do is you can give anti-inflammatory and you can ask the patient to wait. Usually it will again go away by itself. And the third instance where the infection is the reason for the trismus which is occurring, in which case you have to treat it as a infection into the pterygomandibular space and manage accordingly. Probably if the infection, the trismus is associated with swelling on the medial surface of the mandible, probably you can aspirate the site and probably extract a little bit of pus from there if present, or whatever fluid from there if present. You can send it for culture and sensitivity test. Meanwhile, you can give an antibiotic which has proven history of success in the management of the infection. And once you get the culture and sensitivity back, results back, probably you can change the drug accordingly. But even the changing of the drug, also there is a protocol, because with this, the drug you have already given, the empirical drug already given, it has yielded result, or that the patient has become comfortable and the patient is improving and becoming normal, then actually there is no need to change the drug, because whatever drug you have given has treated it. So if there is no reduction in the complaint, then naturally you'll have to go and change the drug according to the what is given in the microbiological result. This is my take on the matter. Thank you.
Thank you, sir. Sir, another question that has arisen is, how far is muscle relaxant successful?
How?
Muscle relaxant. How far can muscle relaxant be successful in managing a case of trismus?
I am not very happy with the use of muscle relaxant. I am more comfortable with the use of heat application and all those things. Muscle relaxant definitely will help you if the only reason for the movement reduction is due to the muscle, that is the muscle spasm. But this is something which you are guessing. So this will only be an added help along with the heat application and all. Actually, it depends upon the individual operator whether to give the other two consultants also might disagree with me. But usually I rather first go and give the hot fermentation and all those things. If it is a very severe this thing, probably the muscle relaxant can be given. But suppose it is due to infection or any other reason, the muscle relaxant is directly not going to help. If the muscle, this is due to an infection or due to the infection arising from there, so naturally the management of that only is going to cure the issue. So that is what I meant by there are three scenarios by which possibly this reduction in mouth opening can occur. If possible, you have to identify each of it and then manage accordingly.
Thank you, sir. So the next question is to Manoj Kumar, sir. The question is that what is the role of enzymes like trypsin and chymotrypsin in managing infections? Sir, unmute you, sir.
Unmute you.
Okay, sir.
Actually, the trypsin and chymotrypsin is useful only if the patient is under antibiotics, that is the infection is active control. Otherwise, you should not give trypsin and chymotrypsin. It will lead to spread of infection from the one space to another space, crossing the barrier, and that will the infection become more worsening. If a proper antibiotic cover under our cover, you can give the chimeral fort or vidancin fort, that is the ratio peptidase or chymotrypsin and trypsin.
Okay, sir. So what about the use of steroids for controlling edema?
Question?
The use of steroids, corticosteroids?
Question to me or?
Yes, sir. Use it.
In active infection case, you should not give the steroids. But in emergency situation like Ludwig's angina, if there is any chances of the anticipating any airway compromise, better to give the hydrocortisone for emergency measures. Otherwise, you should not give the steroid in active infection.
Yes, sir.
No, was the question regarding steroid in presence of infection or to control the inflammation?
So when there is infection.
No, cannot be used.
So what about inflammation then, sir?
Anti-inflammatory. This is an anti-inflammatory drug. So all anti-inflammatory can be used. Trypsin, chymotrypsin, or steroid is. It's only secondary action is anti-inflammatory action. You do not usually give steroid for that action alone. The steroid is given for different reasons. It accidentally has an action of anti-inflammatory thing. So the steroid is never the drug of choice for a as an anti-inflammatory drug alone.
Thank you, sir. Another question to Manoj Kumar sir is, how can we identify pterygomandibular space infection clinically? So the participant would like to know further about pterygomandibular space. So, sir, can you please explain it once again, sir? Pterygomandibular space.
Sameera, it is a good question. In your practice, if you encounter the pterygomandibular space infection, followed by third molar extraction, or due to the iatrogenic infection from the inferior nerve block. So identification is very important. The patient having the having trismus, difficulty in mouth opening, but extraorally there won't be swelling. Swelling is the intraoral swelling. Usually swelling limited to the medial aspect of the ramus. It may extend to the soft palate region, and the uvula is inflamed and deviation of the uvula, and patient can't open the mouth properly. Extraorally, when you palpate the medial aspect of the ramus region, you can elicit the swelling. Otherwise,
is it stuck? How? Only Manoj is paused. Hello. Sameera, what happened?
Yes.
Sorry for the technical interruption.
Now, am I audible?
Yes, sir, you are.
Yes, then I will say something. Regarding the pterygomandibular space infection, how to identify it? I think that was a question. Basically, the pterygomandibular space, masseteric space, temporal space, these are called as mastic.
I think the Dr. Ravindran is muted. Just check.
Sir, mute type.
Sorry, ഞാൻ ശ്രദ്ധിച്ചില്ല. Okay, ഞാൻ പറയാം. Actually, if it is clinically identifying pterygomandibular space infection, this pterygomandibular space infection, masseteric space infection, temporal space infection, all these involve one of the masticatory muscles. So whenever the masticatory muscle is involved or in close contact with an abscess or a inflammatory agent, naturally that is going to spasm, which will lead to definitely the reduction in mouth opening or trismus. But suppose a muscle as strong as masseter is involved, the amount of trismus is going to be very high. That means the mouth opening is going to be comparatively very less. But when the medial pterygoid muscle, which forms the boundary of the pterygomandibular space, is involved, there will be trismus, but the range of trismus will be comparatively less. So identification that there is a little amount of trismus and that the medial wall of the pharynx is displaced laterally. That means there is a swelling in the medial side of the mandible. These two will definitely distinguish it as a pterygomandibular space infection. That is a little bit of trismus plus swelling in the medial side. Mind you, if it is comparatively a larger swelling on the medial surface of the mandible, it could be a lateral pharyngeal space infection also, where the trismus might be there, but it will be, the swelling on the medial surface will be much more, and the trismus will be comparatively less. Thank you.
Thank you, sir. Getting back to Manoj Kumar, sir, for his explanation on the pterygomandibular space infection.
Nair sir already said the pterygomandibular space infection, and if there is any if there is any masticated space get infected, masseter space or pterygomandibular space, masseter space infection, there will be swelling. Masseter space infection will be swelling over the masseter region, but in pterygomandibular space there won't be any swelling extra or usually. Sometimes minimal swelling on the medial aspect. Middle aspect of the ramus. Otherwise, the swelling confined intraorally, that is medial aspect of the ramus, you can't see without the patient can't open the mouth, so very difficult to see in the area. And swelling extend to the soft palate region also, and the edema of the uvula. These are the symptoms what usually occur. That is why should be very careful when we are giving inferior nerve block. The main reason for pterygomandibular space infection, one of the reasons is the iatrogenic infection, that is infection from the needle. When you are giving the inferior alar block, so we have to do the proper aseptic technique when you are giving inferior nerve block. The treatment is incision drainage along the anterior part of the ramus, putting incision anterior part of the ramus, and the sinus forceps is passing medial to the ramus region and dilate the. Through this incision, we can drain the lateral pharyngeal space also, and as I already said, the lateral pharyngeal space, but the direction is different. And that is all.
Thank you, sir. The next question is to Soumithran, sir. A particular participant seeks an answer to: is there any contraindication to do bilateral impaction in a single sitting?
Okay, yeah. So usually when we do impaction bilaterally under LA, usually we don't recommend that because both sides you are giving inferior alveolar nerve block, and that patients will be discomforting to the patient basically, and there will be a tongue falling back feeling for patient. It will be lengthy, 2 impactions, and under LA. Under GA is the only one thing we recommend, where all 4 impactions are sometimes removed, because general anesthesia you cannot give repeatedly. One sitting, patient comfortable, and all impaction can be removed. Usually, definitely we'll be doing only one side impaction only. And if it is very simple and just elevating, coming kind of things, maybe, but still 2-side blocking, because of these reasons, like discomfort to the patient. Some patients become hysteric when you give inferior alveolar block on both sides, and the falling back tongue feeling also will be there. So definitely we recommend only one side impaction under LA. Under GA, all 4 can be removed or 5 can be removed when patient comes with multiple impactions. That's the thing.
Thank you, sir. Another question that has been asked is: how to manage paresthesia following impaction surgeries? Paresthesia following impaction surgeries.
Okay. Yeah. So usually the nerve which is getting injured is the inferior alveolar nerve. Because of close position, you remove it. Most of the time it is a neuropraxia because of the compression on the nerve. You never get neurotomesis and neuroaxonotomesis also, very unlikely. But most of the time, it is the basic simple nerve injury, that is neuropraxia. And it is a lack of sensation in the lips and all the area, you'll get it. The thing is that usually 6 months to 1 year, that will disappear by itself. If you know the regeneration of the nerve thing, that damage will go. And you can add some neurotopic vitamins we give, multivitamins we give, and reassure the patient, and taking consent before procedure. In this case, you're going to have neuropraxia because of these reasons. So that is very important. Tell him that there is a possibility of a neuropraxia which will be there for 6 months to 1 year. And I'll try to minimize that. You avoid all those. That is why you do the coronectomy and split the tooth and don't come. Treatment is basically healing things which is in the hands of the God. 6 months to 1 year time, patient automatically recovers most of the time. That's with the inferior alveoli. The lingual, very rarely, if you manipulate, like Nair was also mentioning, the close proximity and damage, it seems to stand for a longer time and more disturbing for the patient. This still he can manage with the inferior alveolar paresthesia, but the lingual will be very troublesome. Okay.
Thank you, sir. So there is a question from Dr. Sudhir.
Hello. Am I audible?
Yes, yes.
Yes, sir.
Soumithran sir, ചോദ്യം. Sir, antibiotic protocol എന്താണ്?
Question, repeat it.
Antibiotic prophylaxis.
What?
Protocol
Antibiotic prophylaxis.
Protocol for?
Antibiotic prophylaxis.
Antibiotic prophylaxis?
Yes, yes.
I mean, for what? Before doing impaction?
Yes, sir. In general.
Impaction or simple extraction or anything?
Impaction or simple extraction or
yeah.
anything. That is what Sudhir said.
Sir, rheumatic conditions ആണ് ചോദിച്ചത്.
Endocarditis.
Endocarditis.
Okay. Infective endocarditis. Okay. For infective endocarditis, we always penicillins are the one. Usually, sometimes patient will be already on Penidure or penicillin things. Otherwise, what we follow is that 2 grams. There was a lot of controversy on that. 2 gram for 1.5 gram and then 500 gram after 6 hours. Then allergic to that, we have erythromycin combination or vancomycin combinations like that. But usually, we take it commonly. What we practice is 1.5 gram, 500 milligram cap, around 2 grams. No? 2 grams initially, followed by another 500 gram 6 hours after the procedure. This is what we follow. We change into erythromycin only if the patient is allergic to penicillins. Maybe any other newer regimens on that, Manoj? What do you think? Any other regimens are used by you,
Manoj, sir.
or other than this amoxicillin combination?
We are clarithromycin. We are using clarithromycin, azithromycin, clindamycin.
I told about that debatable thing because there was a lot of article which says that for a bacteremia to occur, even while brushing, you can get bacteremia every day morning if the patient is brushing. So are you taking any antibiotic before you brush? So some say it is an extra hype is given on that. So it is again debatable to go on that. Maybe Nair can add something to that on that.
Actually,
what's the thing like?
Actually, the thing is that the American Heart Association and the European Heart Association, actually they have done studies and they have found that the same thing, that is the gingivitis present. Each time the patient bites, technically there can be a bacteremia. Even then, endocarditis is not coming. While doing an extraction, you just remove the tooth. So at that time, the possibility of the bacteremia occurring is comparatively less. Was there a need for this sort of antibiotic prophylaxis? And according to that, some few years back, they recommended that this process can be discontinued to an extent. But recently, it has found that actually this, due to some reason or other, the more cases of infective endocarditis have occurred. So nowadays, we are saying that it is always better to give a infective endocarditis prophylaxis in any susceptible person, because giving 2 grams of amoxicillin is nothing compared to the occurrence of infective endocarditis. So better be safe. Thank you.
Okay, sir.
Sir, അത് കഴിഞ്ഞില്ല. Sir, അതല്ല നമ്മളൊരു 10-20 കൊല്ലമായിട്ട് വരുന്ന ആൾക്കാരുണ്ടാവും. അപ്പൊ അവർക്ക് പണ്ടേ എഴുതി കൊടുത്ത സാധനമാണ് 3 ഗ്രാം കഴിക്കണം എന്നുള്ള കാര്യം. അവര് പിന്നെ ഒരു ഫോളോ അപ്പ് ചെയ്തിട്ടുണ്ടാവില്ല. അപ്പൊ നമ്മുടെ അടുത്ത് പ്രിസ്ക്രിപ്ഷനിൽ സാധനം ഉണ്ടാവും 3 ഗ്രാം കഴിക്കണം. അപ്പൊ നമുക്കത് അങ്ങനെ പറയാൻ കഴിയില്ലല്ലോ. അപ്പൊ നമ്മളെന്താ ചെയ്യാ? നമ്മളത് കഴിക്കാൻ പറയുകയാണോ? ഈ 6 ആമോക്സിലും ഗുളികയൊക്കെ അരമണിക്കൂർ കഴിക്കും കാണുന്ന തന്നെ നമുക്ക് ബേജാറാവും. അപ്പൊ അതിൽ നമുക്ക് അത് ആദ്യം കൺസൾട്ടിങ് അയക്കുന്നതാണോ നല്ലത് എന്നാണ് എന്റെ ചോദ്യം.
3 grams from outdated.
അതിലെ ഒരു ഇഷ്യൂ എന്താന്ന് പറഞ്ഞു കഴിഞ്ഞാല് സുധീറെ,
അല്ല മെഡിക്കൽ ലീഗൽ ഇഷ്യൂ, അതാണ് ഞാൻ ചോദിച്ചത്.
അതിലെ ഒരു ഇഷ്യൂ എന്താന്ന് പറഞ്ഞു കഴിഞ്ഞാല്, ലൈക്ക് ഇന്നലെ മേയർ പറഞ്ഞതുപോലെ നമ്മളെക്കാൾ ഒത്തിരി വിവരം കൂടുതലുണ്ട് എന്ന് അവകാശപ്പെടുന്ന ഫിസീഷ്യനോ കാർഡിയോളജിസ്റ്റോ പറഞ്ഞത് ആണോ ഫോളോ ചെയ്യേണ്ടത്, നമ്മുടെ വിചാരപ്രകാരം 2 ഗ്രാം ആണോ ഫോളോ ചെയ്യേണ്ടെന്നുള്ളത് ഇഷ്യൂ ആണ്. അത് ഫോളോ ചെയ്തില്ലെങ്കിൽ ലീഗലി ഒരു പുല്ലും ഉണ്ടാവില്ല. കാരണം എന്താണെന്ന് പറഞ്ഞാല് there are lots of articles, lots of what you call literature saying that only 2 gram is to be used. Legally, you have done, if you are followed the latest thing, nothing will happen. Even though a cardiologist supposedly with superior intelligence has written this, you can say that he is out of what do you call the present. So you can very well follow the proper protocol as is relevant at this point of time.
Thank you, sir, for clearing that.
Thank you, sir. Sir, as a continuation, നമ്മൾ ഫിസിഷ്യൻ ഒരു ഫിറ്റ്നസ് സർട്ടിഫിക്കറ്റ് എഴുതുമ്പോൾ നമ്മൾ എന്തൊക്കെ പോയിന്റ്സ് ആണ് ഹൈലൈറ്റ് ചെയ്ത് എഴുതേണ്ടത് എന്നുള്ളതും കൂടെ സാർ ഒന്ന് ഡീറ്റെയിൽ ചെയ്ത്.
ഒന്ന് എന്നെ സംബന്ധിച്ചിടത്തോളം എനിക്ക് ഇഷ്ടമില്ലാത്ത ഒരു കാര്യം എന്താന്ന് പറഞ്ഞാല്, I don't like the people writing to the physician for consent. Actually, it is not consent. It is his opinion. The onus is always on the operator or the doctor who does the procedure. That physician is giving his opinion that this can be done. Whether to do it or not to do it is on the operator itself. So coming to your question, actually what to write to the physician. The first you have to understand is myself and Soumithran had been in medical college for a long time. So we know what actually the MBBS people learn during their curriculum. They learn about the dental thing, and most of them are unaware of what is happening. So when you write a consultation, naturally you have to write the name, sex, and all those things has to be written. But I am referring this for, say, suppose for a dental extraction under local anesthesia, possibly requiring a time with adrenaline. If you can write the volume of adrenaline also better, with possibly expecting a time frame of this, that means your reference has to be very specific and it has to be procedure specific. Mind you, if you are referring a case, the reference for an endodontic procedure, where you know that you are not expecting much of bleeding or anything like that, and if you can physician for a patient with the possible bleeding tendencies, the person will be taken through all the battery of tests which is required to possibly prevent the bleeding, which is absolutely unnecessary from your point of view. So you have to mention that instead of writing root canal treatment, you have to say that you are going to explain it further to the physician, almost like to a layman. If you do that, probably they will be able to give a better answer to your question. That's my take.
Thank you, sir. Sir, another question to Manoj Kumar sir is, infection prevail ചെയ്യുന്ന സമയത്ത് ആ ഒഫൻഡിങ് ആയിട്ടുള്ള ടൂത്തിനെ നമ്മൾ എക്സ്ട്രാക്ട് ചെയ്യാൻ പാടോ ഇല്ലയോ എന്നുള്ളത്.
that depends. Offending tooth remove, that depends upon the patient condition. If it is a well-localized infection, like the periapical abscess, and patient's immune mechanism is normal and there is no medically compromised, we can do the removal of the foci of infection. That is the apt treatment for the well-localized infection, like vestibular abscess or periapical abscess. But in cases severe infections and patient's immune status is compromised and other medical morbidity, better to go for the antibiotic prophylaxis. Then, if it is an abscess, first to go for the drainage of the area after proper investigation, like blood investigation and the other consultation. Give the incision drainage. After drainage, secondly, we can go for the extraction of the tooth. In well-localized periapical abscess or endoalveolar abscess, definitely in normal patient, not immunologically competent patient, we can go for removal of the tooth or endodontic therapy.
Thank you, sir. The next question arises to Soumithran, sir. Can we use aeroto handpiece for bone cutting or tooth splitting?
Okay. Yeah, there is one thing also note: the aerota should not be used while doing impaction, mainly for the bone cutting, because the thing is that air will be put into the tissue spaces, leading to emphysema and things like that. Okay, so tooth also, only the crown cutting, we don't split usually with an aerotor even in impactions, because you're opened up the surgical site and introducing air into the deep tissue spaces. So it is not at all recommended. Definitely micromotor with that torque, 12,000, 20,000 RPM is the one we are using with the coolants on that. Never try to use aerotor. Never do for using impactions, doing impactions. Because we have cases of emphysema also. Patient had suddenly, and it can be, emboli can develop and it can be life-threatening. And there'll be sometimes a sudden massive swelling coming in that it can happen in other procedures also, like root canal and other thing. If you push the air, suddenly swelling and obstructing the airways, another thing. Another one is embolism, the risk of embolism.
Thank you, sir. Further extension to that question would be, how do we manage tuberosity fracture?
Okay. Yeah, the tuberosity fracture, the one thing is that you have to do a very good pre-op assessment. You see the third molar and how is the bone around, and you can make out from that itself. There is a dense bone, hypercementosis, ankylotic, and a big mass. Completely, there will be no cancellous spaces. Then you know that this is going to be a tough case, and you may break the tuberosity before procedure and plan. The tuberosity may break while doing. Okay, and isolated third molar also, then it's more likely. And the tooth is not luxating or not yielding. Your simple elevators and all, and the forceps when you're applying also, with a minimal force, you cannot move it. Don't try to exert more force, because you expect a tuberosity fracture. So preventing that is the main one thing. Prevent like that, and if at all you want to remove the tooth and you are planned for removal, then you can, while applying, if you not break the tuberosity, you can straight away go for an open method. Open up the buccal flap, nicely cut the, remove it, and split the tooth and take it very carefully and nicely. And sometimes accidentally you hold on and somebody applied a force and is broken. Without pulling out, just you can see the entire thing moving. Then you know that the tuberosity is fractured. You stop the procedure there. You can go back. Sometimes, so don't remove the tooth, tie it with the wire, leave it there, and plan it for an open method later. Or sometimes what we do is you can reflect a flap. Sometimes you can separate out, and if there is only a small chip of tuberosity side on the buccal side, you can gently take it out and suture it very well. You may not cut the greater palatine, but if you vigorously pull it out, tearing out and taking the whole thing, there will be no oral communication. Greater palatine will be cut also, and you'll have severe bleeding. Okay, so that's the best thing. Plan it for a later time and do it like that way. So otherwise, what we do is reflect it out and try to remove it. Otherwise, you leave it there, remove the tooth there, and you can think of doing a root canal and leaving the teeth there also. All options are there. But precaution and prevention and pre-op, nice preparation and anticipation. And medical legal consent also is very good. Is there a shortage of questions? Or is it time up? Manoj?
Actually, she has asked the question: how to manage surgical emphysema to Dr. Soumithran. How to manage surgical emphysema? She has requested Dr. Soumithran to answer.
Is a question?
How to manage surgical emphysema?
Oh, management of surgical emphysema.
Yes.
Oh, that is a tough thing to ask. I am not an expert in surgical emphysema management. I can relieve the pressure if it is obstructing the airway area by opening up or reducing the pressure. I always take very fast to the physician and tell about the problems of embolism, which you don't leave about that high risk. And try to get a medical consent at the earliest. If at all you suspect something like that, patient should be observed. Because at any point of time, nearby that time, an embolism can develop. An obstruction area, maybe you can think of, but with the air inside, I don't know how you evacuate that air also, which is already gone into the floor of the mouth area. And I have never encountered that in my hands also. So I'm not an expert in that, and I can't give expert comments with my evidence. Better don't create it and don't learn such techniques also.
What is the legal point in leaving a root tip? Okay. Technically, if you think the tooth is a part of your body, you are removing it because you think it's going to cause some issues. But if there are 3 roots and if the particular root doesn't have any infection, it is a normal root with a vital pulp. And if the tip is fractured, nothing is going to happen. There is no issue for leaving the tooth there. And suppose there is a deeply impacted tooth, which is possibly, or whose removal can possibly injure the deeper structures like nerve. There is a procedure, established procedure called coronectomy, where you cut the crown off and leave the root there. So, leaving the root there is not at all an issue because you have a valid reason that at your point, at your hands, or your technically facility, the problem is going to be more while attempting to remove the tooth. That means, as mentioned earlier, the risk versus benefit, in your opinion, the risk is more in attempting to remove the tooth. So you have removed it. The question is, the legality comes is whether you have deliberately left it and did not inform. If the question is that this is an accident, a fracture of a root is an accident, that none of the accident is not going to come as your negligence. It is not a negligence. So the legally, you are absolutely safe in leaving the tooth. Only thing is that patient has to be informed. You have to write it down. Your records has to be perfect even before the patient gives the complaint. Because once your record is perfect, that means you have been truthful and you have followed your thinking that this is going to cause more problem if you attempt to remove it. I think that is the way it should be done. Thank you.
Thank you, sir. Another question for Manoj Kumar, sir. If a patient has got a recent history of hospitalization, a recent or a viral what precautions taking?
Okay. First of all, you have to go through the case sheet and patient records and find out the relevant findings. And viral, if there is any history of recent viral infection, as the surgery is concerned, we have the bleeding problem that is due to sometimes certain viral fever. There is a chance of platelet count will be used. So in such cases, better to give a thorough blood investigation like complete blood count, that is the RBC, platelet, and the PVC count, and the ESR, and just go through the and proper history has to be taken. And hospitalization, you should inquire what is the reason for hospitalization. Is it, and that the question depends upon the what is the medical history.
Okay, sir. What about if a patient reports with acute pulpitis? Should we be prescribing antibiotics in the first place, or should we be relieving the pressure build-up?
Definitely, there is no indication for antibiotic. Just relieving by putting an access cavity opening and relieving the pulpal pressure, then patient get relief. And if the SOS, you can give the analgesics. Antibiotic is not required.
Thank you, sir. So another question is to Soumithran, sir. How far is piezo surgery useful in impactions, surgical removal?
Okay, yeah. The main, I have not much used piezo surgery, but as per the whatever literature we have studied and from the talks and the things we have seen, the advantage of piezo system is that it selectively cuts the bone alone. It doesn't injure the soft tissues like the vessels or the things. It's not damaged, and nicely you can cut and clean cuts, and there will not be much bleeding while cutting the bone. Okay, these are the advantages of piezoelectric system. It is of much more use in other bigger surgeries we do, like resections and ameloblast or orthognathic surgeries and all. It is of much better use. But here also, there are articles on piezoelectric system compared with micromotor and lasers. Lasers also, there are bone cutting thing. Comparative studies are there. Of course, piezo system offers the best result compared to the other one. But you need a lot of money, expense to be spent on that. And of course, the charges on patient will come, and an expertise. You have to using a piezo system and get an expert in that. It's definitely a thing which may completely replace our micromotor, what we are using. And the coolant thing, another thing. Yeah, it's not get overheated. That's another advantage.
Thank you, sir.
In implant surgery also, it is of wide use.
Thank you, sir. And we have the last question for the day, and it is to Nair, sir. Does adding plain serratiopeptidase along with antibiotics help?
I don't know, because why do you want to add serratiopeptidase? Serratiopeptidase is an anti-inflammatory drug. Especially if you are giving antibiotic for an infection reason, giving a serratiopeptidase is actually you are going to remove the barriers which the body has placed to prevent the infection, spread of infection. So to me, adding a serratiopeptidase in such case is not useful. If you are giving a serratiopeptidase for some other reasons other than inflammatory swellings, I don't think it is required, and I have never given it in my life. Thank you.
Thank you, sir. By this, we come to the end of the question and answer sessions. Over to Dr. Madhavankuti Bharathan, the Secretary of IDA Malabar branch, for delivering the vote of thanks.
Good afternoon, friends. We had a very informative on oral and maxillofacial surgery. The Stalwarts, as the name suggests, poured in their knowledge for all of us. IDA Malabar wishes all the oral and maxillofacial surgeons in our branch a wonderful day on this occasion. A very big thank you to our faculty members, Dr. Ravindran Nair sir, Dr. Soumithran sir, and Dr. Manoj Kumar KP sir, for the most informative session we had. Let me thank Dr. Sameera, who is the first vice president, for moderating this webinar, and also Dr. Ikram for assisting and help joining Dr. Soumithran sir. Thank you very much, Dr. Unnikrishnan, for hosting this meeting on the Zoom platform. We had a total participation of around 93 on Zoom as well as the YouTube channel. Thanks to one and all who attended the session, and also for making this webinar very lively with all their questions. Our next CD hopefully will be a physical one. We will be in touch with you all on our social media platform, the WhatsApp. I request you to please go through the official groups at least once a day. Renewing the membership is also very important. Those who have not renewed so far, please do so online as soon as possible, or call your secretary for any assistance. Thank you. And over to.
Thank you. Thank you very much, Madhavan Kurti, and all IDA official bearers, Manoj and Nair, and all the participants. Thank you very much.
Thank you, sir.
Bye.